Good afternoon, everyone. We can start now, and more people are likely to join in a few more minutes. We have a guest speaker today, Dr. Sayan Mukherjee. He is actually my batchmate and also an alumnus of JJ Hospital and Grant Medical College, and one of our toppers. So I hope you have a lot to take away from today's session. I will share my screen and give you a brief overview of what we're going to be learning today. So we will be discussing common medical emergencies that you might see as an intern and henceforth as a MO as well, and further on in your career. So we'll be discussing most of the medical emergency briefly, along with what is the management, what can you actually do in practice. And after that, we'll be covering cases. So I'll be taking the cases part of it, and Dr. Shan will be giving you the theoretical background and information that you need to know. So I think I'll hand over to him. Today, it's likely to be a longer session because it's a bigger topic. But I hope you guys are still able to learn a lot and gain a lot from this session.
This module is designed to focus on medical emergencies, but as you know, the topic is quite vast, so we can't cover it in all full detail, but we'll just give you a brief approach to what the initial step should be when you encounter a certain scenario. So I'll start with a very common scenario, dehydration. Now, dehydration, it's something that you can observe in many different pathologies, right from, say, diabetic ketoacidosis, or a patient who's vomiting a lot, or someone who has had prolonged diarrhea. So dehydration can be seen in all these cases. So it's very important to know how to assess the fluid status of a patient. So that's the first thing that I'm going to focus on. So whenever a patient comes to you with, and you see that he has, you suspect that he has lost a lot of fluid, you inquire about what the mode was. So if it's diarrhea, you take a note, how many episodes of diarrhea, what was the volume, whether the patient was taking fluids when the diarrhea was ongoing. And similarly for vomiting, you can also inquire about the number of episodes, what kind of fluids the patient was taking. So that's the history part of it. It's very important to know how much the volume of fluid has been lost. And then one more important thing is thirst. If the patient is thirsty, it's likely that he or she has taken fluids. But at times, patients are unable to take fluids orally. So at that time, the dehydration can actually be exacerbated a lot. So that's something you should have in your history as well. Moving on, once you've taken the history, you should go on to the examination part. And the first thing you should check of the patient is vitals. The most important thing there is the blood pressure. If the patient has lost a lot of fluid, then in that case, he can have hypotension. For our fluid assessment, we keep the cutoff as 100. If the patient is having a systolic blood pressure of, let's say, 94 or 96, then we can consider that he has lost some amount of fluid. And when a person loses fluid, the sympathetic responses in the body takes over, and that leads to tachycardia. It's another sign that is seen. And one more important thing that you should also check while checking the BP is the postural drop. Now, what I mean by postural drop is you check the BP when the patient is lying down, and you recheck the BP when the patient is standing. You see there's a postural drop in the blood pressure. That is also a very sensitive sign of fluid loss. That is something you should do. Apart from this, you should also check for skin turgor and capillary refill. I'll show you an image for that. Yeah, so this is capillary refill. So you take the patient's finger and you just press on his nail bed for 5 seconds. And when you apply pressure, the nail bed will start getting blanched. It will start getting white. And after 5 seconds, you release it. And as you release it, the blood will again start flowing into his nail bed, and it will again become the normal pink color that is seen in everyone. So what you have to do is you have to count how many seconds it took for the white nail bed to become pink again. So in patients with dehydration, their blood flow can be a bit less at times, especially in the peripheries. Since the nail bed is at the periphery, if the patient is having some form of fluid deprivation, his capillary refill, which is signified by the pink, the reappearance of the pink color, it can be a bit delayed. So it is a good marker for fluid deprivation. Generally, we consider 2 seconds or more as dehydration. As you can see, if it's more than 2 seconds, you need to note it as dehydration. And if it's more than three, then it's probably severe form of dehydration. One more test that you can do is skin turgor. Basically, when a person is dehydrated, the elasticity of the skin is lost. So normally when you pull your skin up, as it's shown in this image, and leave it, it's expected to go back as soon as you leave it. But in a patient who has some form of dehydration, it will take a long time for that skin fold to go back to its original state. This is called tenting of the skin, and this signifies loss of skin turgor, which is also a good marker for dehydration. I'll come back to this third image later. Just a second. So yes, we've assessed the blood pressure, the heart rate, and postural blood pressure drop. We've seen the skin turgor and capillary refill time. So now it's time for you to give some therapy. So generally we give IV fluids, but hypotension, it can have many causes. And we should first make sure that the patient is fluid responsive. So generally what we do is we give a small fluid bolus and see if the hemodynamic parameters of the patient is improving. Let's say his blood pressure was 94 systolic, and we give some fluid, and his blood pressure after 15 to 20 minutes becomes 110. So it's said that the patient has fluid responsiveness. So if the patient is fluid responsive, we can go on with our fluid resuscitation. We can continue giving the fluid. So one other test that can be used in this context is called passive leg raising. So I told you, when we want to check for fluid responsiveness, we give a bolus of fluid. Generally, we give it from outside. We give maybe a 250, 500 ml of saline. But there's one more test that you can do in the bedside instead of this. It's called the passive leg raising. So the patient is lying in this manner, and you raise his lower extremities. And generally, we have a vascular system in the lower legs which contain a lot of blood. So when we raise the patient's lower extremities, all this blood in this manner, all this blood returns to his heart. So essentially, it's acting as an endogenous bolus. The fluid bolus which you are giving from outside, we are just replicating that with the patient's own blood. This is called passive leg raising test. Similarly, you will check after doing passive leg raising, similarly like the fluid bolus from outside, you will check his hemodynamic parameters, his tachycardia, his blood pressure. If you see they're improving, so that means this patient has a positive passive leg raising test, which means he's fluid responsive. So we can go ahead and start giving him IV fluids. It's just another easy test for, instead of giving a fluid bolus in reality, you can use this endogenous fluid, that is his peripheral blood in his lower limbs. So once you've started fluids, it's very important to see if the patient is going into an overload state. It can so happen that we give more fluids than what has been lost, and that could lead to an overload state in the patient. So two things you can check for are peripheral and pulmonary edema. So generally, we'll check for peripheral edema in his presacral area if he's lying down. We will check for peripheral edema in his legs if he's sitting or standing. Apart from this, pulmonary edema is also is commonly seen in fluid overload. To check for this, you need to perform auscultation of the lungs, generally at the lung basis. How you do this, you will auscultate posteriorly for the lung basis, and you can hear some crackles. In the bibasal crackles, we call it. The both bases of the lungs will show some crackles. This is also a sign of fluid overload. We don't rely completely on clinical examination. We would generally go for an X-ray, and the X-ray would show features of pulmonary edema. We have a module on chest X-ray coming up. So we'll have visuals there. You can see the chest X-ray of how pulmonary edema looks like. So once you've done your assessment, you've started your fluids. So there are some things you need to monitor. The first thing is the IO chart. That is an input-output chart. Generally, it's maintained by the nurses. You'll see they have a chart in the bedside. When they give fluids, they keep entering it. And most patients are catheterized. So they check the catheter bag and see how much output has come. So generally, it's a good measure of how effective our fluid resuscitation is. Next, we can monitor for weight loss or weight gain. Generally, if a person loses a large amount of fluid, it will start reflecting on his total weight. So if you check his weight, if his normal baseline weight, he has, let's say it's 60 kg, and now his weight is around 54 when he's admitted. So that means he has lost 6 kg of weight, a 10% loss in body weight. That's due to the loss of fluid. So he's quite severely dehydrated, and we need to monitor his weight. And when we give fluid rehydration, we have to see how his weight is coming back to normal. Apart from this, all patients should have some blood work done. So most important is the urea, creatinine, electrolytes. you already know that a patient with dehydration is going to have a elevated urea and creatinine. We can monitor the urea and creatinine as we give our fluid rehydration. It's expected to come down. And electrolytes should also be monitored. These patients who are very dehydrated, they can have a wide array of electrolyte abnormalities. They can have hypernatremia sometimes, they can have hyponatremia, so on and so forth. So it's good to monitor it periodically. So now that we have done the monitoring part and assessment part, we need to go into the actual fluid rehydration part. So what choice of fluids do we have? I mean, we have two types of fluids mainly. One is crystalloids and one is colloids. So can you comment, name a colloid and a crystalloid in the comments?
All the MBBS
Gopal,
intern, you can all comment in the chat, or
just one of each will do.
Yeah, I'm sure you guys know this. Chat, I'll let you know if anyone comments in the chat. You can stay on the presentation.
Slide. Right. So yes,
MBBS intern, batao, no one has answered. Yeah, ringalactate. Seema has answered ringalactate. Colloid is albumin. Ajish has answered.
That's right. Perfect. So yeah, crystalloids generally you can have, generally these are small molecules such as like sodium chloride and dextrose, that's basically glucose. All these are small molecules which are dissolved in water. So they are called crystalloids. And if you're using large molecules like human albumin, or one more is commonly used hydroxyethyl starch, HES. All those are colloids, they're large molecules. What you need to remember is for IV dehydration, in the case of dehydration, we use crystalloids. And our preferred fluid of choice is 0.9% sodium chloride. The first dose that we give, we call it a bolus dose. We give a 500 ml of 0.9% sodium chloride, which is called normal saline, over 15 minutes. This is the fluid bolus dose, and we check the hemodynamic response. We'll check the blood pressure, we'll check the heart rate after giving this. So generally, the patient's vitals will start getting normal. It won't turn normal with just one bolus, but it will gradually trend towards normalcy. So we keep giving these boluses and we keep checking them. So 15 to 30 minutes, 500 ml of crystalloids over 15 to 30 minutes, we keep giving them and we keep checking them. And slowly the vitals will start to get normal. Suppose the patient doesn't show normal vitals even after fluid resuscitation. What is the endpoint? The endpoint we have from the guidelines is used, NICE guidelines. It says that after you have given 2000 ml, that is a total of 4 bags, 4 500 ml bags of sodium chloride, normal saline, you should ask for senior help, because that's the even after giving 2000 ml, if the patient is not showing any response, that means there can be some other pathology which needs to be investigated. Generally, these patients, they need vasopressor support. Vasopressor support is something that's given in the ICU. So yeah, I'm not covering that here. I'm just covering the IV dehydration part. But you need to go for you need to escalate this patient for senior support. Similarly, you have to also look for signs of shock. So these are the two endpoints you can say for rehydration and escalation. Signs of shock, that this patient is having hypotension, which is not responding to fluid, is having very severe tachycardia. Or if we have already given 2000 ml and there is no change in the parameters as compared to what it was in the admission time. In such case, you will escalate. Suppose you have given all the fluid resuscitation and the patient's hemodynamic parameters are improving. Would you stop the resuscitation? You won't. We'll start fluid maintenance. There are two parts of rehydration. One is fluid resuscitation, one is fluid maintenance. So we'll give him maintenance fluids. Now it depends on the body weight of the person. So I've used a body weight per kg calculation. So let's say the patient is 60 kgs and we are using 30 ml per kg per day. So his fluid requirements would be 1800 ml, that's 1.8 liters per day. Similarly, for sodium, potassium, and chloride, 1 millimole per kg per day. You can calculate it according to the body weight of the patient, and you can check how much sodium and potassium is present in the fluid that you're using. Generally, it's between 134 and 150, the crystalloid solution that we use. And then again, for its energy needs, you need to give glucose in the form of dextrose. Sometimes you can combine them too. It's called DNS, dextrose normal saline. In this way, to perform fluid resuscitation as well as maintenance fluids. And yeah, that covers the topic of dehydration in a very general approach, nothing specific, the basic fluid resuscitation that we cover. So I'll move on to the next topic now. Another GI based topic, upper GI
Shan, we
bleed.
have a question before
Yeah,
you move on.
sure.
Priya has asked, just the molecular size is different. Is the reason for crystalloids are preferred over colloids, or
No,
any
there are
other reason?
actually multiple reasons. Actually, studies are done. So we're using both and we see the response. And on basis of that, these guidelines are chosen. But I'm saying crystalloids and colloids are different on basis of their molecular size, but also what responses they elicit when they're given. And it's been shown by many studies that when you use crystalloids, the resuscitation is better, the endpoints are achieved in a better way. That's why they're preferred, crystalloids. But yeah, the molecular size is.
Okay. Priya, to also answer your question, it is always a point of contention about the NS dena hai, RL dena hai, ki, what exactly, which fluid we want to use for resuscitation. But after multiple studies where they've tried using both and assessing the patient's response, they found that NS was the best fluid you can go with for dehydration. And now this is a patient who has come in the hospital to you, right? वो hospital में आया है with dehydration. Another simple way of rehydrating a patient is, if they can take fluids orally, you can give them ORS. And can anyone tell me what is in ORS? What are the contents? Good. So Urmi has said glucose, citrate and lactate, right? Sodium, potassium, glucose, right? So even ORS itself is sodium chloride, is NaCl, right? So even oral hydration can be given using ORS if the patient is awake and can take it orally. In a clinical setting and in general in life, you have to realize that it's always better to follow the physiological process. अगर patient orally input fluid ले सकता है, तो orally देते हैं. Unless the BP is so low that they cannot, take the fluids orally. But in general, we would still prefer oral hydration wherever possible. And as Shayan mentioned, another point I'd like to add, skin turgor. Skin turgor is especially important in children. जो तुम्हारे neonates आएंगे या those young children, they will have signs of dehydration which are very obvious. We'll cover that in pediatrics. But again, very nicely explained by Shayan about how skin turgor is assessed.
Okay, so the next topic, upper GI bleed. This is actually, you'll find a lot of patients coming to the emergency department who will tell you I vomited up a large amount of blood. So generally, it's seen in alcoholic patients because they have something called variceal varices. They have varices. Varices are basically dilated veins which are present in many parts of the body, but esophageal varices is what we'll focus on. It's present in the lower part of the esophagus, and the veins are dilated due to processes in the liver that due to cirrhosis in the liver, certain pressures are elevated, leading to the dilation of these veins. So they can spontaneously rupture at times, leading to large volumes of blood, which are sent into the esophagus and are vomited up. So this is variceal hemorrhage, and the other cause of it is non-variceal hemorrhage. One of the prominent causes is bleeding from the peptic ulcers. That's one cause. Apart from that, there's something called Mallory-Weiss syndrome, especially seen in alcoholics. When they vomit forcefully, leading to small lacerations and tears in the esophageal mucosa, leading to bleeds. There are other causes too, but I'll just focus on two causes, that is variceal bleeding and non-variceal bleeding. The cause that we'll discuss is peptic ulcer bleeding. So the basic that I'm going to cover is what you should do in the emergency room, because the definitive management is endoscopic management, which is something that the gastroenterologist would do. But what would you do in the emergency department? So Rupali must have taken this class on resuscitation and triage, where she has talking about the ABCDE approach, which is airway, breathing, circulation, disability, and exposure. So first you will check the airway of these patients. Why should you check it? Because they generally vomit a lot of blood, and while vomiting, some amount of blood may go into his airway as well. So you should check his airway whether it's completely patent. If not, you should start protecting his airway using airway adjuncts. You should check whether he's breathing properly. You should check circulation. It's quite important to check circulation. That's because if a large amount of blood has been vomited up, the patient can be hypotensive. The patient can be in hypotensive shock as well. So in that case, you need to resuscitate appropriately. And then you check disability and exposure. Those are not very important here. The first thing you'll do, you'll insert two large bore IV cannulas. Generally 18 gauge or 16 gauge is preferred. Why large bore? Because it allows you to give a large amount of fluid in a relatively short amount of time. So you can resuscitate quickly. And after you have done this, you will arrange for blood. You'll draw a blood sample from this patient and send a lot of tests. But first, you should send a blood group and cross match. So you must have seen the tubes. There are plain tubes and EDTA tubes. So you'll take one plain, one EDTA, and one more plain for actually two plain and two EDTA. The first set is used for his blood grouping, and the second set is used for his cross matching. So you send this as soon as possible to get the blood ready from the blood bank, because these patients can deteriorate fast. And in that case, you would need blood ready. Many units of blood, 2 to 3 units of blood may be required urgently. Apart from this, you will send the routine investigations like CBC, LFT, RFT. LFT is important here because the patient can have a hepatic derangement, because these patients generally have a background of chronic alcoholism and cirrhosis. So yes, IV fluids and blood we have done, and blood transfusion if it's required. If the IV fluids, it's just a stopgap measure, IV fluids, and when blood is available, you start administering blood. This is fine. After this, so there are certain other things you need to administer if certain criteria are met. So first, if the platelets of this patient are below 50,000, you have sent the CBC, and the CBC has come and you see it's 30,000 only. So it's good to send good to get a bag of platelets and start transfusing platelets too, if it's less than 50,000. Now, this fresh fusion plasma is often used if the prothrombin time is more than 1.5 times the upper limit of normal. So each lab has a certain range for prothrombin time. So you check the upper limit and you multiply it by 1.5. And if your patient's prothrombin time is more than that, he may need fresh frozen plasma. Apart from that, other products such as cryoprecipitate can be given if fibrinogen is low. And if the patient is also taking warfarin, in that case, you have to use something called prothrombin concentrate, prothrombin complex concentrate, to reverse the effect of warfarin, because the patient is already bleeding from his varices and he's also on warfarin, so that will prevent the hemostasis from occurring quickly. And there's one more thing that's not really available everywhere. It's recombinant factor 7A. So if everything fails, it can be used. So I've just added it for some theoretical value. Generally, it's not really available everywhere. It's difficult to procure it. So once you have done this basic thing, which is the resuscitation part, you send him for endoscopy. So ideally, you should send each patient as soon as possible. But suppose you're having a lot of patients who are queued up for endoscopy. In that case, you send the ones who are hemodynamically unstable first. Others should get it within 24 hours. But ideally, you send them as soon as possible. So once they perform the endoscopy, they'll get to see what the pathology is. If there are varices, they can see the varices. We can see the dilatation of the veins in the lower part of the esophagus. And if it's a if it's a stomach bleed from a peptic ulcer, they can localize the ulcer and see the bleed and the clots that are there. On the basis of that, they can perform some interventions too. For example, there's something called banding, variceal banding. So these dilated veins, they are banded together, just like a elastic band you can use to close a parcel or something. You can just apply a band on the varices to stop it from bleeding. Apart from them, there's something called sclerotherapy, but it's not superior to banding. Banding is more preferred. But if the varices are in the stomach, then sclerotherapy may be used. So just remember these two things, sclerotherapy and banding, which are done by the gastroenterologists. And once the endoscopy has been completed, you give him a high dose of intravenous proton pump inhibitor. You can use omeprazole or pantoprazole. Why you shouldn't give it before is that it can mask the endoscopy findings at times. So it's better you do it after the endoscopy is done. And if the bleed is confirmed to be of variceal origin, then terlipressin is a specific drug that is used in this context, and it's given for up to 3 days. It can improve the mortality and the morbidity of these patients. It's been seen. And you also give antibiotic prophylaxis. Now, this is important because a large amount of blood is going into the stomach. So it's a protein load. So in these patients who are alcoholics, they also have a risk of spontaneous bacterial peritonitis and things like hepatic encephalopathy. So antibiotic prophylaxis is generally given. Something from the cephalosporin group is preferred for these patients. And this is something you don't need to cover in detail, but I've just added it because it shows a risk stratified approach. So basically, it's the same thing. If you go through it, it's basically the same thing that they have told you to insert cannulas, fluids, blood. then proton pump inhibitors. But this you can make a note of. It's called the Glasgow-Blatchford score. So basically takes into account multiple parameters like hemoglobin, blood urea, systolic blood pressure, and other things. So on basis of that, they calculate a score, and on the basis of the score, they perform multiple interventions. You don't need to memorize this, just for your reference, because it's often used in many hospitals. So yeah, this is just see it after the slide, after the presentation ends, just check it. Yeah, any questions on upper gastrointestinal bleed?
Nothing in the chat.
Nothing,
Chan, you
right.
can go ahead.
So we move on to acute kidney injury. Yeah, so acute kidney injury, it's seen in seen quite commonly. It's a result of multiple other pathologies. Commonly, it's due to hypovolemia. If the patient is having a severe degree of dehydration and his total blood volume is less, in that case, the kidneys can start receiving less blood and can go into acute kidney injury. It's called prerenal AKI. Similarly, certain nephrotoxic agents like aminoglycosides, they can cause damage to the kidney itself. That's called a renal acute kidney injury, renal. And sometimes it can be post-renal. In post-renal, generally, there's a stone or some form of obstruction in the urinary tract that blocks the urine flow from the kidney to the bladder. That's called post-renal AKI. So this is just some etiologies. That's not very important here. What is important is how do you define an AKI? How do you suspect an AKI? The main thing that you see is a serum creatinine. You track the serum creatinine, and for the first time when you take the blood, that serum creatinine, you call it the baseline creatinine, and you monitor the creatinine, whether it's rising, at what rate it is rising. These are some criteria which are used internationally. A 50% rise in the serum creat in 7 days. Let's say his first value was 1, and now when you have done it, it's 2. So it's a 50% rise. 1.5, I'm sorry. Initially it was 1, and now it's 1.5. So that's a 50% rise. And similarly, 26 micromole of rising within 48 hours. That's another criteria. You have to just memorize these things. The third one is quite important. Less than 0.5 ml per kg per hour for 6 hours is urine output. So generally, you'll catheterize these patients, so you can easily quantify how much urine is passing. And 0.5 ml per kg, let's say 60 kilograms his body weight is. So if his output is less than 30, for 60, it's 60 to 0.5, that's 30 milliliters per hour. So if his output is less than 30 for more than 6 hours, so you can say he's at risk and has AKI. These are some criteria which can be used, but generally a rising creatinine is sufficient to suspect an AKI. And these are certain patient groups that you should be cautious about. Someone is already having a chronic kidney disease, they can have a greater chance of developing AKI. A diabetic patient, again, has higher chance, and contrast agents. Generally, this occurs about 5 to 7 days after the contrast has been given. So contrast, like iodinated contrasts, are frequently used for CT scans. So the patient will be fine after a CT scan is done, but after a few days, it may be seen that his creatinine is rising. So that's called contrast-induced AKI. One important thing you need to know is these patients may not always be anuric. That is, their urine output may not be low always. It can also be normal. I mean, maybe little less than normal, but not less than 0.5 ml per kg per hour. So it's called non-oliguric AKI. You can remember that. And elderly patients are at greater risk. And just as I told you, sepsis and hypovolemia. So it can occur in the background of sepsis and hypovolemia. The patient is having a low blood volume, or the patient is having sepsis with hypotension, that can lead to an AKI. And one more thing, if the patient is having some form of structural disease of the urinary tract, some form of obstruction in the collecting tubules, some stone, in such case, a post-renal AKI is also quite common. So yeah, certain investigations that you need to do, just basic investigations, send in for an ultrasound of his kidney and urinary bladder, check for any stones, see whether it's post-renal. If you see a stone, then it's post-renal, so you'll send them to the urologist for management of the stone. If not, you can understand that it's probably pre-renal or renal AKI. So you can do a urine routine microscopy. You can look for casts, you can look for cells, things like that. And then a UCS, if you're suspecting some form of infection, maybe it's a background of pyelonephritis or something, then you can do a UCS and other routine investigations like RFT, LFT, and UNE, that's urea and electrolytes. You can expect a rise in creatinine in this LFT. So yeah, you do it for that reason. And this is a brief overview of the AKI management. So it's a lot of text. I'll simplify it for you. So So basically, you have to understand what are the problems that AKI has. The AKI itself, if you don't treat the AKI itself at times, you have to treat the associated problems that it brings. The first thing is hyperkalemia. Any renal disease, be it CKD, be it AKI, there's a good chance that the potassium will rise because of reduced excretion by the kidney. So you check his, so as I told you, you send a urea and electrolytes of this patient. So when you do that, if you find the potassium is high, how high? Let's say more than 5.5. So if it's more than 5.5, you do a 12 lead ECG. And the ECG will see certain changes. Rupali must have taught you in the ECG module, the changes that are seen in hyperkalemia. Generally, you'll see tall T waves, and that's a very common sign. And then in severe forms, sine wave pattern and things like that are seen. But just remember tall T waves. If you see ECG changes, that means his heart needs to be protected. So we give something 10 ml of 10% calcium gluconate. Why we give this? It's not to reduce his potassium. It's to stabilize his heart's membrane. You see, when potassium is very high, it can lead to an arrhythmia. The heart becomes very unstable from an electrolyte point of view. It can trigger an arrhythmia, ventricular tachycardia, something like that. So when you give calcium gluconate, it will prevent that. It will make the heart more stable towards arrhythmias. So once you have stabilized the heart, next we'll focus on how to reduce the blood potassium levels. So generally what we use is a GI drip, a glucose insulin drip. So use both glucose and insulin. Why do you do that? Because insulin promotes the intracellular shift of potassium. The potassium goes from the blood into the cells by the action of insulin. But if you give insulin by itself, it will cause hypoglycemia. So to prevent that, you combine it with glucose. So that's the second line of treatment. And then salbutamol is a beta-2 agonist, which is, you must be familiar, it's used in asthma. It also has the same action as insulin. It promotes the movement of potassium into the cells. So yeah, it's also used in hyperkalemia. Apart from that, if the patient has metabolic acidosis, you can give 8.4% bicarbonate. And these patients can have both overload as well as dehydration in terms of fluid. So if they're in overloaded state, which is seen in form of pulmonary edema, you can treat the pulmonary edema. Generally, you go for IV furosemide, and then if the patient is very breathless, you can give IV diamorphine, not commonly given, but it can reduce the breathlessness of the patient. And if they're not responding, you can go for escalate the treatment to CPAP and so on. And apart from this, if it's depleted, then just you go for a fluid dehydration, then, as I told you in the first slide. And then for the cause itself, you try to find out what caused it, whether he's receiving any nephrotoxic drugs, whether he's having an infection, and you treat the cause accordingly. Just remember the problems: hyperkalemia, metabolic acidosis, and fluid overload or dehydration, and treat the causes. Apart from this, there are certain things that you should keep in mind, that if the potassium is very high and not responding to your treatment, or if he's having severe acidosis and he's not responding to your sodium bicarbonate, in that case, you have to send him for hemofiltration, that is dialysis. And generally, you don't need to know the details, but just know the indications for dialysis in a patient of AKI. So hyperkalemia, acidosis, and uremic symptoms. These three are the common things that are common reasons why they're sent for dialysis. So I'll move on to the next one, acute pyelonephritis. Acute pyelonephritis is also, you can call it upper UTI. What is upper UTI? Lower UTI, when we say, we generally mean something like urethritis, something like cystitis, that is the infection of the bladder. These are quite not very serious, they're not life-threatening. So you can just treat them on an outpatient basis with antibiotics. But acute pyelonephritis involves the infection of the kidney itself. And it can be a quite life-threatening situation. So that's what, so yeah. So the general symptoms of these patients are flank pain. Now, flank is basically part of your, just below your rib cage on the lateral side, you can say. That's the flank. That's basically represents where the kidney pain is usually felt. It's called flank pain. And then since these patients have a bacterial infection of their kidneys, they have high fever. And they can also have signs of sepsis, neurosepsis, if it's very severe. So tachycardia, tachypnea, and a reduced blood pressure. So there's something called Q so far. It's very simple, actually. You just see three things. You see their respiratory rate. Is it more than 22? You see their mental status. Are they confused? And you check their blood pressure. Is it less than 100? If the answer to any of these things is yes, then there's a chance that he's going to sepsis. So you'll escalate the treatment accordingly. So yeah, I just include this because it's important to recognize sepsis early for effective management. So you must do a Q so far. Whenever you think there's suspicion of sepsis in any pathology, be it a respiratory sepsis or a urosepsis. Yeah. So what one more important thing is the risk factors of an upper UTI. So yeah, the first thing is female gender. Second is an indwelling catheter. Whenever patients are catheterized, there's a colonization of the catheter and it leads to a greater chance of an infection. Diabetes mellitus and structural disease, some form of malformation of the urinary tract. So that can actually cause, that can actually have a greater risk of uh, upper UTI, stones. And IVD, what is IVD? Intravenous drug users. Generally, they inject drugs using syringes which are not very sterile. And these things can cause a small bacterial to be small amounts of bacteria to be introduced in the blood, and this can lead to some bacterial clots, which can affect the heart, leading to infective endocarditis. And these bacteria-laden clots can get embolized, and this emboli can land in the kidney, leading to a upper UTI. So you need to know that intravenous drug users are at a greater risk. So yeah, this is, you don't have to memorize this, just some antibiotic choices. So yeah, cephalexin. Cephalexin is used, coamoxiclav. Ciprofloxacin, which is commonly used, ciprofloxacin, trimethoprim. These are all the oral antibiotics. And if the patient is very severely unwell, you're suspecting sepsis, then you can go for IV. So the dosages are given, ceftriaxone, coamoxiclav, again ciprofloxacin. This is the usual treatment, but you need to remember what if a pregnant woman comes to you with an upper UTI? Then you use cephalosporins, use cephalexin for oral, and for intravenous, you use cefuroxime. These two are very safe in a pregnant patient. So you can't use other medications like ciprofloxacin, which is not allowed to be used in pregnancy. Yeah. Any questions on nephro? I'll move on to endo then.
I have a question for
Yeah.
all the interns here. How many of you have seen the input-output chart, and how many of you have seen changes of electrolytes on an ECG? Now that you are in the hospital, I'm sure you must have seen a few ECGs. If you've seen it, you can put a yes. If you haven't seen the ECG changes, you can put a no. Because this was one of the ECGs that we discussed in the previous class, and nobody got it. Everyone was giving different answers to what the ECG was. So I'll show that ECG again once at the end of Sayan's presentation, and we'll try to figure out what it is again. Because that was an electrolyte imbalance, but everyone was confused if it's a MI, if it's a normal ECG or whatever. So my point here is, whenever you're in the hospital, whenever you get the opportunity, take the patient's ECGs, look at the files, especially if they're renal patients, if they're respiratory patients, check their ECGs, if they're chest pain patients, because that's how you'll start to learn. That's how you'll understand what you're supposed to look for and what it actually looks like in real life. Okay, and with UTIs, again, as Shayan mentioned, very common in pregnant women and also children. So young girls will present with complaints of increased frequency, burning micturition, and things like that. Again, in our own hospital in St. George, we get a lot of kidney stones. So they come with flank pain, and the flank pain is radiating to the back and things like that. So you can sort of immediately come to the conclusion, okay, maybe there is a stone. Then you can get a X-ray done, followed by a USG and things like that. So these are very common conditions, and you should at least know the risk factors and what they present as before you move on to further management. Okay, Chan, I think you can come.
Yeah. The next topic will start endocrine, diabetic ketoacidosis. It's very important to know the management of this, as yeah. So basically, these patients are type 1 diabetic, general symptoms, polyuria, polydips, all of you know it. But it's very important to know that they are very severely dehydrated, these patients with DKA. And apart from that, they're acidotic. So one way the body tries to compensate for the acidosis is by increasing ventilation, so that the carbon dioxide is blown off. It's basically a respiratory compensation to the acidosis due to the ketones present in the body. So they will be breathing. Yeah, sorry. Yeah, so they'll.
You can continue.
Okay, fine. So they'll be breathing very fast. It's called Kussmaul respiration, Kussmaul pattern of breathing or air hunger. The first thing you'll see, they are dehydrated. They are breathing very fast. And there's something, there's a presentation like acute abdomen. It doesn't present always as acute abdomen, but it can also present as acute abdomen. In that case, you may be confused. So you must remember that acute abdomen is also a presentation in DKA, along with the other features. Some of these patients can be confused at times due to the severe dehydration. Can have confusion, and they can have vomiting too. There's something you'll see in the textbooks, fruity smell due to the ketones that are released from the lung. That's sometimes it's seen, sometimes it's not. But it's, you should remember that fruity smell due to the ketones. Generally, why does it happen? Like the patient is a type 1 diabetic, and there has to be some precipitating factor for DKA to develop on a background of type 1 diabetes. Most commonly, it's due to an infection. These infections can lead to a stress on the body, and the patient can go into a decay. Sometimes decay is the first presentation of a diabetic patient. They were never diagnosed and they have extremely high blood glucose levels, something like 500, 600. Along with that, they'll have a fruity odor and then dehydration, unresponsiveness. Decay presents like that too as an initial presentation in some patients. And then some patients are non-compliant to their medications. When they don't take their medications and insulin on time, it can lead to progressive worsening of their glycemic control, and then it can precipitate a decay. That's also, whenever a patient comes with suspected decay, when you have done his assessment and you suspect decay, his draw his blood. So before drawing his blood, you check his blood glucose levels. So you use a strip-based glucometer, just prick his finger and take his capillary blood and check for the blood glucose. Generally, it will be very high. Once you have done that, your suspicions are even more confirmed that it's a case of DKA. And then you send his bloods. When you draw a sample of blood, send some of it to for a venous blood gas. You can take an ABG also, but whatever venous blood you draw, that can also suffice, because we are looking for the pH mainly, the degree of loss of bicarbonate, the base excess, things like that. It can be done on venous blood too. You can't secure an arterial blood. And then you send the blood for plasma ketones and blood for glucose. The first one was capillary glucose. This is venous glucose. Send them both. And then the usual things like urea electrolytes, look for dehydration, RFT for dehydration, and send his urine sample for urine ketone detection. Generally, it's a strip-based test. So they have these small strips which change color on coming in contact with the urine, depending on the concentration of ketones in urine. So you can match that against a standard. You can get an approximate idea. Generally, it will show 1+ ketones, 2+ ketones. So you can get a rough idea of the ketones in his urine. Yes, but there are certain criteria that must be met before we can label a patient as DKA. So you can remember them if you want. The blood glucose is more than 11 millimoles per liter. I have used millimoles per liter. You can convert them to milligrams per deciliter. Same thing. More than 11 millimoles per liter. Serum ketones more than 3. Urine ketones are positive. And the pH is less than 7.3. Basically 3 things: hyperglycemia, ketonemia, and acidosis. They just put some numbers on it. So once you have these 3 criteria in your hand, you can say that this is a case of DKA. But even before that, you have to start treating him for his dehydration. So I'll go to that next. So yeah, there are 3 actions. I divided it into 3 actions. First is that we have to treat his fluid deficit. Second, we have to give him insulin to reduce his ketogenesis in the body. And third, we have to look at the other electrolytes, which can be deranged due to the dehydration and other things. So to estimate the deficit, we use a formula, 100 ml per kg. Let's say he's 60 kgs in weight. So it's 6,000 ml, that's 6 liters of deficit. So we can start our rehydration according to that. We should remember this pattern: 1 liters over 1 hour, then 1 liters over 2 hours twice, 1 liters over 4 hours twice, and then 1 liter over the next 6 hours. This is generally, it's a accepted algorithm that's used for rehydration. So yeah, what is important that what you should remember is the fluid of choice is 0.9% sodium chloride, that is NS. You should also remember that this NS, when you give the NS, it also has other actions. It also reduces ketogenesis and also reduces the pH. So just insulin. So insulin alone won't suffice. You have to rehydrate the patient adequately to completely reduce the ketogenesis. And once you have, also alongside this fluid replacement, you have starting insulin at the rate of 0.1 units per kg per hour. And once the insulin starts to take its action and the blood glucose starts falling, and it's less than 14 millimoles per liter, then you can reduce the insulin infusion to half. That is, instead of 0.1 U per kg per hour, you make it 0.05. Also note that in the fluids replacement section, I've added once blood glucose is less than 14, start 5% dextrose. That is because we don't want hypoglycemia. Because the insulin is still being given and his blood glucose is falling. And now we don't want it to fall too low. So we'll start by giving some amount of dextrose at 125 mils per hour so that it falls predictably. We don't end up with hypoglycemia. And this infusion shouldn't be stopped. It should be continued till the patient is normal, he's mentally fit, he's conscious, cooperative, he's having his food, he's drinking water, things like that. And when he starts continuing his food and drink normally, you can stop the infusion and switch to whatever regimen of insulin he was on. He must have been taking some form of insulin long acting and then bolus, something like that. Start his regimen and stop the insulin infusion. Now, potassium is also an ion you need to take a look at. In patients of DKA, potassium can be high or low both. If the potassium is between 3.5 and 5.5, you give 40 millimoles of potassium. If it's more than 5.5, we don't need to give anything. If it's less than 3.5, if it's hypokalemic, ask for senior support. This is the general guideline that's followed. And for the patient's acidosis, you don't need to give him bicarbonate. Whatever fluid and whatever insulin you're giving him, it will automatically suppress the ketogenesis. And when ketones are not produced anymore, the acidosis will correct itself normally. So you don't need to give XCO2 from outside. Phosphorus, you don't need to give phosphorus, but if he's having low phosphorus, if you have checked, then you may use phosphorus, but it's generally not used. And sometimes you have to give venous thromboembolism prophylaxis because these patients, since they're very dehydrated, their blood flow in certain peripheral veins are quite sluggish. And a sluggish flow can promote thrombogenesis. So sometimes you discuss with your seniors, and if they think it's fit, you can offer him venous thromboembolism prophylaxis. So to recap, just three things you need to note: fluid replacement, 0.9% sodium chloride. Then once the glucose is less than 14, you start with 5% dextrose. Then you give insulin at 0.1. Once it's less than 14, switch it to 0.05 and take a look at potassium. If it needs replacement, replace it. Else, don't do anything. This is the general management of DKA. And there's one more condition which is quite similar to DKA, but also quite different. That's called HHS, hyperosmolar hyperketotic state. HHS. Hypovolemic hyperosmolar state, not ketotic. Ketones are not present in HHS. I'm sorry. HHS is hyperosmolar hypovolemic state. So the definition of hyperosmolar hypovolemic state is hypovolemia. How will you ascertain hypovolemia? You use the assessment methods I told you in the first slide that you use for dehydration, tachycardia, decreased blood pressure, decreased skin turgor, increased capillary refill time, things like that, posture will drop. And apart from that, the osmolality of the patient will be very high. How will you calculate osmolality? Is very simple. This formula here in the bottom, it shows that 2 times sodium plus glucose plus urea. So when you send his bloods, you'll have his urea values, glucose and sodium. So this you'll calculate 2 times sodium plus glucose plus urea. So this is his osmolality. It's more than 320 usually. And there's a marked hyperglycemia. And there is no ketonemia. That's very important. In DKA, ketones are a central theme. Ketones, we are always trying to reduce the ketones, and ketones are a major part of the management plan. But here, there is no significant hyperketonemia. So it's just hyperosmolarity and hypovolemia with hyperglycemia. Right? It's seen in type 2 diabetes mellitus generally. And it's a more progressive thing. It doesn't happen overnight. It will take some time, maybe some 7-10 days. The patient generally would have reduced oral intake, reduced fluid intake. So gradually the change takes place. And since it's gradual, it's much more severe because the pathology has more time to develop. So when they come to you, they have much more severe dehydration compared to DKA. And they have a much higher blood glucose level as compared to DKA. So yeah, so I'll just cover it shortly, the management. It's quite similar to DKA. You use 0.9% sodium chloride, but remember the dehydration is much more severe. So instead of 6 liters, you may need to give 10 liters. The deficit is much more. And then insulin is not needed. Why isn't it needed? Because there is no ketonemia. You don't need the insulin. Just start him on IV fluids and the pathology will automatically correct itself. Now you can give insulin under certain conditions where there is a significant ketonemia. You see without significant ketonemia, it says it's less than 3 millimoles per liter. If for some reason there is a coexistent thing and if you see the ketones are more than 3, Only in that situation will you use insulin, but routinely there is no role for insulin. Similarly, for potassium and phosphorus, it's similar. If it's less than 3.5, ask for senior help. If it's 3.5 to 5.5, you give 40 millimoles. And if it's more than 5.5, no replacement is needed. One more point you should remember, the patients who have HHS, they have a high risk of foot ulceration. So you must examine their foot every day. If you see any forms of ulceration, then you should notify the surgeon immediately, because already he has very high levels of blood sugar and the healing process would be very slow. So it needs to be taken care of quickly. Foot ulceration. Yeah.
Sayan, there's a question.
Sure.
D. Terence has asked, is Ringer's not preferable here since it has bicarbonate?
Not really. I mean, generally 0.9% NaCl is the best fluid here. You don't need to give bicarbonate additionally. Because the acidosis, which is there, it's not, it's due to the ketones that are forming. So to treat the acidosis, we have to reduce the ketogenesis first. Giving bicarbonate, it won't really solve the cause of the problem. So we have to focus more on reducing the ketones. So we'll let insulin and 0.9% NaCl, hydration and insulin together will reduce the ketogenesis, and that will automatically reduce the acidosis that the patient has. You don't need to give any fluid that has HCO3. It's not required. That's the thing.
Okay. Also, I would like to mention, so in on the group, I had sent a few videos about respiratory patterns. In that, we have Kussmaul's respiration, so that you can see what it looks like if you ever come across a DKA patient. And just this morning, I had a night shift, and in the morning, we had a patient who came with a known diabetic. He took his morning medication, and his blood sugar levels were 320. Okay. And he had done his HbA1c a few days ago, so that was 11.8. And so basically uncontrolled diabetics will come to you, and there is a sliding scale of insulin that you need to understand. कि हर patient जो आता है उसको तुम कितना insulin दोगे? How do you know if you need to give 2 liters of 2 units of subacute insulin, 5 units of subacute insulin, 10 units of subacute insulin? So that is again something that you need to learn when you start seeing diabetic patients, because again DKA is very common, and since diabetics are also immunocompromised, they are very prone to infection. तो एक तो उनका डायबिटीज अनकंट्रोल्ड है एंड ऊपर से बहुत कॉमनली इन्फेक्शन हो जाता है, तो दैट विल प्रेसिपिटेट देम इनटू गोइंग इनटू डीके और गोइंग इनटू एन एचएचएस, राइट? एंड यू विल आल्सो सी दैट once our medicine residents are called and we've got a serum ketone, a urine ketone value, then they'll be like, okay, अब इसका ABG करो. The third step that he has mentioned, the pH less than 7.3, the bicarb less than 15, all of that is seen on an ABG. So we'll be covering a session on ABG where I will teach you what metabolic acidosis looks like, because these patients are going into acidosis, and that's where the bicarb comes in. So when you have that acidosis, you can correct it. But as Sayan mentioned, the underlying pathology is not the bicarb imbalance. It's that the patient is getting dehydrated. It's that the sugar level has risen, right? Okay. I will share the sliding scale of insulin कि कितना sugar बढ़ता है तो कितना insulin देते हैं on the group itself after the session. So you will have that as a reference whenever you come across these patients. Sayan, you can go ahead.
All right. The third thing that we will cover in endocrine and diabetes especially is hypoglycemia. It's a very common. It's very commonly encountered in the emergency room. Many patients will come to you with unconsciousness, and you'll ask the family members. They'll tell you that he takes some medicine for his diabetes, or maybe he takes insulin. Generally, what happens is these patients have taken their insulin or their sulfonylureas, and they have not eaten adequately. So they land up into hypoglycemia, and that can cause certain symptoms, which I've listed here. It's called the Edinburgh hypoglycemia scale. So basically, it's the common symptoms that you see in a hypoglycemic patient. So the first thing is the autonomic nervous system. It starts getting dysregulated. So the patients start sweating, palpitation, you start feeling hunger, and start shaking. Very common. You must have seen someone with hypoglycemia. They have sweating, palpitations, and when the hypoglycemia progresses to a more severe degree, the brain starts getting less glucose. So it's neuroglycopenic, but the brain starts getting less glucose. So patients can start getting drowsy. The speech can become slurred. This can start getting confused. So these are some common features of hypoglycemia that we'll frequently encounter. So as I said, certain patients have excessive, they've taken insulin and are not eaten. So that can be a cause. Certain types of diabetic drugs, they can reduce the blood glucose level, and sulfonylureas are the most common. You must be knowing glimepiride, gliclazide, drugs like that. So suppose a patient has taken a high dose of sulfonylureas and has fasted for some reason. So you can land into hypoglycemia. Apart from this, a very important cause is alcoholism. So this is a patient who doesn't have diabetes, but he is a chronic alcoholic. What alcohol does to the liver is it causes cirrhosis. And while cirrhosis is taking place, glycogen, which is the storage form of glucose in the liver, it gets depleted. So the patients don't have any backup of glucose. So whatever glycogen we have normally, it starts releasing when we go into hypoglycemia and corrects it. But these patients have no reserve of glucose, so they'll directly start going into hypoglycemia. It's very common. Alcoholic hypoglycemia is very common. And there's something you need to know about alcoholic hypoglycemia. That is, before you start with glucose, you must give thiamine. Thiamine is a vitamin. It's deficient in alcoholics. And when it's also required in the metabolism of glucose. So a hypoglycemic alcoholic comes to you, you give him glucose itself. So the body will start metabolizing glucose and start using up whatever thiamine he has left. And this will precipitate Wernicke's encephalopathy. We don't want that. So we always give thiamine on 100 to 200 milligrams. We give them thiamine and then we give the glucose. Or we can give it together, but never after. Thiamine should always be given together or with the glucose. And then there's a rare cause, insulinoma. It's an insulin secreting tumor of the pancreas. It's very rare. I just mentioned it for theoretical interest. And then the cutoff that I've chosen is less than 4 millimoles per liter. Again, it's in millimoles per liter. We generally use milligrams per deciliter here. The guideline I used, it had this unit, so I used it. You can easily convert it online. The calculators are available. So this is a very good management pattern of how you should approach a case of hypoglycemia. So they have three categories: mild, moderate, and severe. So as I told you, see this symptoms. They're in the hypoglycemic scale. Patient may be sweating, may have sweating, palpitation, shaking, but he may be conscious, but he's conscious. He can talk to you. He can have oral fluids. Such a case we call mild. In the moderate section, the patient is conscious and is able to swallow, but he's confused. So he's confused, but he's not unconscious. And in the third case, he's unconscious. This is the basis of the classification. It's basically about swallowing. A patient who is conscious and is able to swallow, a patient is confused, but he's able to swallow, and a patient is unconscious and unable to swallow. So this will direct what form of treatment we'll give him. So whatever you do the ABCDE first. Once you have done that, remove any IV insulin. That is, maybe he is receiving insulin in the ward, stop it. So if he's able to swallow and he's conscious, give him something orally. There's something called dextrosol tablets, just glucose tablets. If you don't get glucose tablets, you can use a glucose powder, which is commonly available. You make a solution of the glucose powder and give him 100 to 200 ml, or give him fruit juice, which has a lot of sugar in it, and you check the blood glucose after 15 minutes. If it's still less than 4, or if it's still less than the threshold that we have set, we can continue this 3 times. Give him glucose 3 times. And if he's still hypoglycemic, then it means that we need to give him IV therapy or some form of parenteral therapy. And so we'll classify him as severe. Let's look at moderate. These patients, they are not fully oriented. They are conscious, but they're very confused. So we shouldn't make them swallow something. Instead, we'll give them something that's absorbed from the mouth itself. Generally, some glucose gels are found. It's not always available everywhere, but it's a type of preparation of glucose which is easily absorbed through the buccal mucosa, through the mucosa of our mouth. So he doesn't have to swallow it. You just put it in his mouth, just like sorbitrate, that is GTN, glyceryl trinitrate. It's given sublingually. It gets absorbed through the buccal mucosa. Similarly, this one, this glucose gel is also absorbed through the buccal mucosa. So he doesn't have to swallow. He's conscious. He can retain that thing in his mouth, and then he can easily have that. Then it can easily get absorbed. So that's for moderate. Again, you'll do it 3 times, just like mild. And if it's not working, you go for the severe form of treatment. In severe, there are 2 approaches that you can have. One is IV dextrose, and the other one is glucagon. And generally, glucagon is not freely available everywhere. So generally, IV glucose is the commonly used thing that we use in the emergency department. So if it's a 20% dextrose, you give him 100 ml. If it's 10%, you give him 200 ml. And over 15 minutes. Now, in certain situations, the patient may be having seizures because hypoglycemia can cause seizures, and he may be shaking violently, making it impossible to secure an IV access. In such a situation, you might use glucagon because it's used intramuscularly. You don't need to secure IV access. You can just give 1 milligrams of glucagon. But there's something you need to know about glucagon. Glucagon is not glucose. It just mobilizes the glucose, which is present in your liver. So in certain situations, the glucose storage in the liver is depleted. So just as I told you a few minutes back, alcoholic doesn't have glycogen in his liver. It's all depleted due to cirrhosis. So if you give glucagon to a alcoholic patient who is having hypoglycemia, there won't be any effect on him. Similarly, if somebody has prolonged starvation, all the glycogen in his liver would be converted to glucose and used up. So in such case, you give glucagon, there is no glycogen left to mobilize. So glucagon is not used. In the last line, you may be seeing that it's useless in severe liver disease, sulfonylurea-induced hypoglycemia, and alcoholics. So that's a point you need to understand. Should I go ahead, Rupali? Does anyone have questions?
Yes, go ahead. No
One
question.
short
Does anyone have a question? Okay.
There's one. Okay, fine, I'll go ahead. The next topic is thyroid storm. I've covered it very briefly. Basically, it's hyperthyroidism and leading to certain life-threatening features, you can say. I've just classified the features system-wise. So tachycardic, the patients will be tachycardic. And you must remember if a patient has a background of heart failure, it can precipitate heart failure due to thyrotoxicosis. And atrial fibrillation is also very common in patients of thyrotoxic storm. CNS agitation, anxiety, things like that, in gastrointestinal nausea and vomiting, very general things. And thyroid is the thermogenic hormone, the thyroid hormone. So patient has fever since a large amount of thyroid hormone is circulated. So basically, you remember all the vitals are raised. Heart rate is raised, the temperature is raised, and respiratory rate is raised, things like that, along with CNS and serious symptoms. Just remember, it can cause atrial fibrillation, it can precipitate heart failure. And similar to DKA and HHS, it also has precipitants, which are quite similar. Like if there's a stress on the body, like infection or some form of surgery, or if the patient has had a stroke or a myocardial infarction, this can lead to a thyrotoxic storm in a patient who has already a background of hyperthyroidism. So whenever a patient comes to you, whenever you suspect such a patient, just take his bloods and run a TFT. Do a free T3, free T4, and TSH, and also send him for ECG, because I told you these patients are prone to atrial fibrillation, so we should know if the patient is in AFib or not. So just do a TFT along with the other tests, which you'll do obviously like CBC and LFT, RFT, but do TFT and ECG. Once you've done that, we have to manage these patients. Now, it's a very specific management exists for this disease. First thing is, what are the objectives? First, we want to reduce his tachycardia and his discomfort. He's having palpitations, he's having tachycardia, so we have to reduce that. So the drug of choice for that would be propranolol, which is a beta blocker. Beta blocker will reduce his heart rate. And then there's an anti-thyroid drug that we are going to use. It's called propylthiouracil. Basically, it reduces the peripheral conversion of the thyroid hormone into its active form, and thus reducing its action. It's propylthiouracil. And third is hydrocortisone. It's a steroid. That steroid also has a similar effect. It reduces the peripheral conversion of the thyroid hormone into its active form. And then once you have reduced the peripheral conversion, once 1 hour has passed since you have started this treatment, you can go and give him Lugol's iodine. And Lugol's iodine, what it does, it reduces the T4 release. Now I'll tell you what this is. T4 is a hormone that is released by the thyroid, and then it's converted into T3 peripherally. The first 3 drugs that I used, the propylthiouracil and hydrocortisone, they prevent the conversion of T4 to T3 in the periphery. Why is that important? T3 is the more active form of thyroid hormone. So we have started, so what the treatment has stopped the peripheral conversion of the T4 into T3, which is an active form. And now we want to stop the release of T4 itself from the gland. For that, we use Lugol's iodine. Lugol's iodine will stop the T3 release. So it comes to solution, and we give the solution 1 milliliters every 6 hours. You don't need to remember the dose. It does something called the Wolff-Chaikoff's effect and reduces the thyroid hormone release from the gland itself. Now, apart from that, the patients have fever, so you control that with PCM. Don't use salicylates, that's aspirin. because they can displace the thyroid hormone from the storage form in the gland. So it can exacerbate the symptoms of thyroid storm. And the patient has a CCF, cardiac failure, treat that. If the patient has some form of dehydration, treat that, just symptomatic. Apart from that, you just need to know these four names: propranolol, propylthiouracil, hydrocot, and lugolsartan. Yeah, endocrine ends here. So we'll move on to respiratory, right, Rupali?
Yeah, just a specific thing I wanted to mention for thyroid patients. These will be generally females who are, say, around in their 30s, 40s, and they will be on medications usually. वो बताते हैं हम thyroid की गोली लेते हैं, thyronorm पे है, and all of that. So in females especially, try to take a history of thyroid conditions. How you ask patients की diabetes, hypertension है, ask them thyroid है क्या, कोई गोली चालू है उसके लिए, नहीं है, because a lot of these women might come present with an arrhythmia. They might complain of कि palpitation हो रहा है वगैरह, and then later you might find out कि okay, why is it happening is because they are thyroid patients, उनके medications ऐसे चल रहे थे and things like that. Okay, so sometimes you have to work the other way around. Your history is very important when you're seeing females especially who are thyroid patients. Yeah, that's it. That's all I wanted. You can go ahead.
Okay, so we'll move on to a new section now, respiratory. The first thing I'll talk about is pneumothorax. So pneumothorax, self-explanatory term, means air in the thoracic cavity. Normally, the air is in the lung, and the thoracic cavity has small amount of fluid that separates, that facilitates easy motion of the lungs. So if for some reason the pleura is punctured and the air of the lung starts leaking into the pleural space, that's called pneumothorax basically. What you need to know is there is a variant of pneumothorax called tension pneumothorax. So what happens is the air from the lung starts leaking into the thorax, that is the pleural space, but not the other way around. Whatever air enters the pleural space stays there. It's unable to find its way back to the lung. So it keeps accumulating. This is what is called a one-way valve. The air only moves from the lung to the pleural space, not the other way around. So remember, tension pneumothorax, it's a life-threatening emergency and you need to act really fast to save their life. Why is it? Because it leads to obstructive shock. If the pressure inside the thoracic cavity rises so much, it starts compressing the great vessels and the heart. So it leads to an obstructive shock. So yeah, a good sign for this pneumothorax is a raised JVP, and then the trachea is generally deviated due to the large pressure that's generated on the side that has the pneumothorax. And then again, if you perform auscultation and if you percuss, you have a resonant note, but you don't rely on that. You rely on a chest X-ray. If you suspect it, send in for a chest X-ray. And on chest X-ray, a black lucent shadow is seen. I've not included the chest X-ray, but we have a session on that. We will be explained about the features of pneumothorax in great detail. Generally, the patient will come to you. There are two forms, right? The tension pneumothorax and non-tension. The first line is generally for non-tension pneumothorax, a dull central sudden onset chest pain with shortness of breath. That is the non-tension variant. And if on top of this, there are features of obstructive shock like hypotension, tachycardia, raised blood pressure, raised JVP, then you should suspect tension pneumothorax. And there are certain terms you need to know: PSP and SSP. Primary spontaneous pneumothorax. These are the cases of pneumothorax which develop in a person who has no underlying respiratory pathology. And SSP, that is a secondary spontaneous pneumothorax, it occurs in setting of lung disease, most commonly COPD. The COPD has these large air-filled cavities called bulla, which often rupture, and that leads to pneumothorax. Apart from this, certain traumatic events like a road traffic accident can also cause pneumothorax. If a lung biopsy is taken, it can also cause a pneumothorax. It's called iatrogenic pneumothorax. Basically, three things you need to take note of: high flow oxygen, needle aspiration, and intercostal chest drain insertion. This next slide, it focuses on what intervention you should go for. You can easily understand in a primary spontaneous pneumothorax, the treatment is a little less aggressive as compared to secondary spontaneous pneumothorax. So if you measure the size of the pneumothorax, how do you do that? I'll send an image on the group. I should have included it. Basically, there's a distance I need to measure. If it's between the between the collapsed lung and the rim of the pleura. If it's less than 2, you can give him high flow oxygen. You can discharge it if it's a case of primary spontaneous pneumothorax. But if the patient has a size which is more than 2 centimeters, or if he's symptomatic, then go for needle aspiration first in a case of primary spontaneous pneumothorax. Basically, needle aspiration is, I have an image here. Yeah. So yeah, this you see a needle being inserted into the chest cavity. The level of the insertion is the fifth intercostal space, and the line you can see, the orange line which is being drawn, that is the anterior axillary line, which is basically the pectoral fold. This is the preferred site for needle thoracostomy. That is, we insert a needle, we evacuate all the air that is present in the pleural cavity. So generally, we use a wide bore needle, 14 to 16 gauge is preferred for easy flow of air, and we insert it at the fifth ICS at the anterior axillary line. And third thing is, you try to insert it on the through the upper border of a rib, not the lower border. Why you should know this? Because there are certain vessels, the intercostal vessels are nerves which traverse through the lower part of a rib. So you avoid the lower part, you insert the needle along the upper border of a rib. And once you insert this needle, you'll see a hissing sound, which signifies air escaping from the pleural cavity outside. So once you have done that, it's successful. You have reached the affected pleura, and you let the air hiss out. And once you've done that, you send the patient for a post thoracostomy X-ray, and you see whether there's improvement in the X-ray. You can see here if needle aspiration is successful, that's the second point. And if the CXR shows less than 2 centimeters, initially it was more than 2, now it's less than 2. So you have drained some air. So you can give him some oxygen and discharge him if it's in the primary spontaneous. But if the residual air is still more than 2 centimeters, despite your intervention, despite your needle aspiration, you need to insert a chest drain. Yeah, and now we'll move on to the secondary part. It's a bit different from the primary one. It's much more aggressive. Instead of the 2 centimeter cutoff, we have chosen it to be 1 centimeter. So only if it is less than 1 centimeter will we do a conservative management. We'll give him oxygen and we'll monitor him with a chest X-ray to see the size of the pneumothorax. But if it's more than 1 to 2, just check on the other side, because here it was mentioned more than 2. But on this side, we have chosen it to be between 1 to 2. So if it's between 1 to 2 and the patient is not significantly breathless, we can go for a needle aspiration. Same thing, anterior fifth intercostal space, anterior axillary line. And if it's unsuccessful, if the size doesn't change much, insert a chest tube. And then again, if the patient is breathless and if it's more than 2 centimeters, again, insert a chest. You don't really need to remember all this. It's just a guideline. What you need to remember is there's something called needle thoracostomy, which is done. And there's something called ICD, intercostal chest drain. See this. So it's basically a tube. It's a tube which has certain openings on the distal side. These openings, when you insert the tube into the pleural space, in between the pleura and the collapsed lung, and this tube has some openings which allows the air to enter the tube and starts exiting the pleural space into this bottle that we have set up here. The bottle basically has some water in it, and the tube which is inside the chest, it's submerged. This is what is called an underwater seal. It's very important. Whenever you see a patient who has a chest drain, you will notice the bubbling. Basically, it's due to the underwater seal. And once through the underwater seal, there's another exit which leads to the atmosphere, that leads to the exit of the air. This whole setup, you must remember the chest drain and the underwater seal. Now, chest drain, where is it inserted? You remember this is inserted in the fifth ICS anterior axillary line, and chest drain is inserted in this roughly triangular area. It's bounded by quadrangular area. It's bounded by the fifth ICS below, base of the axilla above, and medially it's bounded by the pectoralis major's edge, and laterally it's bounded by latissimus dorsi. This entire space you can insert a chest tube. Yeah, that's about it. So you just remember high flow oxygen, aspiration, and chest tube. What are the sites? What are the indications? And also be familiar with the chest X-ray finding, which we will teach you in the next module. Yeah. So next one is pneumonia. Very common presentation. Generally, patients will have a high-grade fever. They'll have cough, and when you ask them, "Does something come out when you cough?" They'll say yes. They'll say yes. Yellowish, greenish, sticky things, sticky sputum comes out. It's called expectoration. It's classical of pneumonia. And sometimes they can have chest pain. Now, this chest pain is called pleuritic chest pain. What is pleuritic chest pain? Pleura is the covering of the lung. So whenever there's an underlying infection in the lungs, the overlying pleura can also get a bit inflamed, and that causes pleural chest pain because the pleura has nerve endings, so it's sensitive to pain. And this pain is generally peripheral. The pain of a myocardial infarction is central. It's near the sternum. It's substernal, crushing central substernal pain, radiating. It has a typical description. This one, it's not so severe and it's located peripherally. So once you have suspected the patient to have a pneumonia, do ABCD like always, and then do the routine investigations, IFT, LFT, and CBC. CBC will probably show you a raised WBC count. Do a CRP ASR. These are markers of inflammation. If it's very high, then you can think of sepsis. Maybe sepsis might be setting in. And then you will do the QSOFA assessment, or you check the blood pressure, respiratory rate, things like that. And then your important thing is you'll take a sputum sample and you'll do a sputum routine microscopy to look for pus cells, bacteria, and you'll do a sputum culture sensitivity. The sputum has bacteria in it, and that will show us some form of antimicrobial susceptibility. So once you get that report, you can tailor your antimicrobial regimen so that the drug you're using is sensitive for the bacteria you're killing. And then you must do a ABG also, because these patients can be hypoxemic, and a chest X-ray. Generally, you do all of this together. This is not in any sequence, but just remember chest X-ray, ABG, sputum culture and sensitivity, and routine microscopy, and blood tests. Just normal things: CBC, RFT, LFT, CRP, and ESR. Next, I want to introduce this CURB 65 score. Very useful. It's a risk stratification tool. It has a total of 5 parameters. You can see here: confusion, urea more than 7, respiratory rate more than 30, systolic blood pressure less than 90, diastolic less than 60, and age more than 65. You have to remember this. Each of these things carry a 1 point. And on basis of the point, you can decide the treatment. So yeah, CURB 65, and then 1 point each. So how would you decide the treatment? Yeah, so this is it. If you have 0 to 1, it's called the low severity of pneumonia. If it's 2, it's moderately severe. If it's more than 3, it is high severity. And each of them has a specific way of treating them. The first one, if it's low severity, you can just give him oral amoxicillin. Oral amoxicillin, give him a course of oral amoxicillin, he should be better. But if the patient is having a moderately severe pneumonia, we give him 2 antibiotics instead of 1. Amoxicillin along with clarithromycin. Amoxicillin is a penicillin group antibiotic, and clarithromycin is a macrolide. Sometimes doxycycline is also used, but just remember amoxicillin plus clarithromycin. In high severity cases, we will go for intravenous broad spectrum antibiotics. We'll admit the patient, we'll give him supportive care, give him fluids if he needs it, we'll monitor the blood pressure, and we'll give him intravenous antibiotics. Amoxiclav, instead of just amoxicillin, we use amoxicillin plus clavulanic acid. And along with that, we use clarithromycin. Now, if Legionella is a specific pathogen, and if you have reason to suspect that the pneumonia is caused due to Legionella, because it has some other features such as hyponatremia and things like that, you can add a fluoroquinolone, that is levofloxacin. But just remember, as a summary, if it's a non-severe form, just go for oral amoxicillin. If it's moderately severe, oral amoxicillin plus clarithromycin. And if it's very severe, amoxiclav IV plus clarithromycin IV. And it's all on the basis of the CURB score. Yeah, this is just the dosages. What you don't need to remember this. I've just added it for reference. Dose of amoxicillin 500 mg TDS, and the IV doses as well. Amoxiclav 500 125. Yeah. Should I proceed to call it to asthma?
Yes, no question.
Okay. Asthma exacerbation. Let's note that we are not dealing with asthma per se, just with exacerbation. Often you will have patients coming to your A&E with severe breathlessness, with wheezing, and with cough. When you inquire about the history, they'll tell you that they use some inhalers and they have asthma in their family, or they themselves have asthma and they're on medications. So generally, on a background of asthma, if there is a precipitant, such as a upper respiratory tract infection or a lower respiratory tract infection, or maybe he's exposed to dust, maybe he's allergic to mites, maybe he's allergic to pollen that plants produce in certain seasons. In that case, that can act as a precipitant and worsen his pre-existing asthma. This is called an asthma exacerbation. So whatever tests you want to do, first thing you must do is ABG. You have to look at his oxygen status and his carbon dioxide status. So once you perform his ABG, his PO2 can be low, his PCO2 can be high. Why should his PCO2 be high? Because it's a respiratory defect. Basically, the airways are getting narrowed and the body is not able to expel the gases properly. So he can have hypercapnia, but then these patients have a very high respiratory rate. So carbon dioxide may be normal and can also sometimes be low. And apart from that, do a chest X-ray because pneumothorax can also have a similar presentation. And then go for all the routine investigations that you want to send. Do a CRP, do a CBC, LFT, RFT. But remember, ABG and the chest X-ray are important. And you also should remember something called impending respiratory failure. So generally, these patients would be breathing very fast. If you auscultate their lungs, they'll have wheezing. But then suddenly, if you see that their respiratory effort has reduced, they're not breathing as much. The chest has become silent. They're tired. They're getting drowsy, and they're developing bluish discoloration of their fingers. You suspect that he's going into respiratory failure because his body is no longer able to cope up with the work of breathing that is required to sustain respiration. So he's going into respiratory failure. So you put a pulse oximeter. I will check whether his SpO2 is less than 92 or not. You can give him a handheld peak expiratory flow rate meter and check if it's less than 33 of predictor or not. These are just some signs that you need to remember in a patient of asthma exacerbation, which are indicative of a respiratory failure, which is about to happen. So when you get such a patient, first thing, give him high flow oxygen. Give him a tight fitting mask and start oxygen at 94 to 98. Inside with that oxygen, you give him salbutamol. Salbutamol is generally available as a nebulizer preparation. So it's introduced into the oxygen itself. So the oxygen becomes a carrier gas, which takes the salbutamol into the respiratory system. Salbutamol is a beta-2 agonist, which is used. Ipratropium bromide is another drug, which is a muscarinic antagonist. And it's nebulized. Generally, it's given together, salbutamol and ipratropium bromide. And you also should give this patient oral prednisolone, which is a steroid. If some patients are very tired, they can't take oral medication. So you give them IV hydrocortisone, 100 milligrams. This is our initial treatment. And then if the patient starts developing these features, impending respiratory failure, so that means you need to escalate your line of management. So you can give him IV magnesium sulfate, 1.2 to 2 grams, and that is given. And there's something else that's also given in the next slide. See the third point, patient is still not improving. IV MgSO4 is mentioned, and you can also give IV aminophylline and IV beta-2 agonist, like IV salbutamol. These are certain medications that are used. So you must remember oxygen, salbutamol, ipratropium bromide, prednisolone, and then if nothing happens, you escalate to magnesium sulfate and IV salbutamol. Rarely you can give IV aminophylline because aminophylline can cause arrhythmias. So you don't want to give aminophylline in a setting where you don't have the support to handle an arrhythmia. So that's it. Subsequent managing, it's nothing different, same thing, just tells you that continue your line of management till the patient starts improving. And if the patient doesn't improve, you can go for mechanical ventilation. So yeah, that's a very brief overview of asthma exacerbation. One more exacerbation you need to know, it's COPD exacerbation. Generally, COPD patients, they have a long-term difficulty in breathing, they have cough, sometimes they have expectoration in the morning. So, but they are in a stabilized state generally with medications, but sometimes they can have a sudden worsening of the symptoms where they start becoming increasingly breathless, they develop a high fever, they start expectorating sputum, and they start using their accessory muscles. Basically, they have aggravated shortness of breath. So this is a typical scenario of exacerbation. And there are two things you need to consider when you're thinking of an exacerbation. One is an infection. COPD patients, when they have a pneumonia, it can worsen the COPD symptom. This is the most common cause of exacerbation. It's called an infective exacerbation. And second thing is a pneumothorax. As I told you, these COPD patients have large air-filled cystic cavities known as bulla. This can often rupture and lead to a pneumothorax, and that can also lead to worsening of the existing symptoms. So again, you perform certain investigations, just like the asthma exacerbation. You take a ABG, you take a chest X-ray, and we send routine investigations. And now, since we are suspecting infective exacerbation of the patient of the COPD symptoms, do a septic screen. That is, take his blood, do a culture, take his sputum, do a routine microscopy and a culture, and check his CRP. So these are certain things you check for any form of infection. CRP would be elevated in an infection, and the sputum culture would show any bacteria that are in his sputum, that so that we can give antibiotics accordingly. And also do a ECG. COPD patients, they can have arrhythmias. Atrial flutter, atrial fibrillation are quite common in patients with COPD. So yeah, to summarize, just do a ABG, do a chest X-ray, send routine investigations, and send investigations for an infective focus. Then the management, there's something I want to tell you. This is not like asthma. You can't just give him a tight-fitting oxygen mask and start the oxygen. You need to use a specific form of mask called a Venturi mask. This is a Venturi mask. You see these small attachments, the colorful attachments, each of them are rated for a particular percentage. What does the percentage indicate? It indicates the amount of oxygen that is going. So if you connect a mask, if you connect a Venturi attachment to an oxygen source, and if you start the oxygen source, then it will deliver exactly that percentage of oxygen which is mentioned on the Venturi attachment. Let's say it mentions 30%. So if you use the specific attachment, it will deliver 30% oxygen to the patient, not more. Why is this important? Because our respiratory center in the brain, it has there are many things that stimulate respiration. Low oxygen can stimulate respiration. High carbon dioxide can stimulate respiration. So high carbon dioxide is a very important stimulator of respiration. But in COPD patients, the carbon dioxide in blood, it slowly starts building up, because COPD patients, they have a tendency to retain carbon dioxide. And once the carbon dioxide is high in their blood for a long time, the respiratory center gradually starts losing the sensitivity to raised CO2 levels as a stimulator of respiration. So in that case, low oxygen becomes the primary stimulator of the respiration. And if we give him a large amount of oxygen, 100% oxygen, then the SpO2 will rise to almost 100%. And the low oxygen situation that's in his body, that will disappear. So that respiratory drive, which was coming from the low oxygen in his blood, that will disappear, and he will go into respiratory failure. So you must note that Venturi mask must be used in COPD patients, and 24 to 49 is the general percentage. So the percentage, we call it FiO2, fraction of inspired oxygen, FiO2. You'll commonly see it on ABG readouts. FiO2 is 21% when the patient is on room air. It can be increased or decreased with a Venturi mask. And then, as I told you, watch for CO2 retention. If the CO2 is rising fast, despite your interventions, start NIV. What is NIV? It's non-invasive ventilation. The mode of NIV we use for a patient of COPD exacerbation is CPAP, continuous positive airway pressure, CPAP. And then mechanical ventilation, it's not really used in COPD, but if the patient is having a PaO2 less than 7.3, this if he's strongly hypoxemic, we can give a mechanical ventilation. And apart from that, we'll give him bronchodilators like nebulized salbutamol and ipratropium like asthma. And in this case, we'll give him steroids too, like asthma, and we'll give antibiotics. Now, what antibiotics? It's just like pneumonia, amoxicillin, doxycycline, and clarithromycin, ACD. We read in pneumonia that we use amoxicillin for mild, we use amoxicillin plus clarithromycin for moderate, and for severe, we use amoxiclav plus clarithromycin IV. So it's similar here, amoxiclav. You don't need to remember it separately. Just remember, remember the Venturi mask point, watch for rising CO2, and give him steroids, salbutamol and ipratropium like asthma, and give him antibiotics, give him amoxicillin. And these patients often have copious secretions that are present in their respiratory tract. So you call the respiratory physiotherapist and ask him or her to administer chest physiotherapy for draining the secretions. You can also use certain mucolytic agents like N-acetylcysteine, or you can just nebulize normal saline to ease up the secretion so that they can be expelled. Yeah, that's the end of the respiratory section. Any questions?
No questions, Sayan. You can move on to cardiac.
Okay. Okay, so Rupali must have taken a section on ECG in the previous. I'll just do a recap. I'll just mention the treatment. So this ECG, does anyone know what it is? Anyone in the comments?
whoever attended last time session, what is the rhythm? What is the rate? We start from there always. What do you see? Okay, can anyone just tell me what the rate is from the ECG? You can put it in the chat.
Anybody?
Okay, sinus rhythm. Okay.
Okay.
And rate.
So maybe I'll zoom it in a bit. Just see lead
150. Okay. Moapati Vaigdevi has said tachycardia, 150 heart rate.
Okay, you're close. You're close. It's definitely tachycardia. And it looks suspiciously like sinus rhythm, but it's not. If you see the P wave, there is no P wave.
Yeah,
Just
Prashant
before
has
the
said
Q1.
absent P wave. Yeah.
Exactly. That's correct. And it's absent P wave, but the rate is regular. As I can see, it's tachycardic, it's regular, and the baseline is fine. It looks straight to me. There's no irregular baseline. So this is not atrial fibrillation. It's not irregular. And it has a regular baseline. So this is a case of PSVT, that is a paroxysmal supraventricular tachycardia. This is a type of narrow complex tachycardia. So tachycardia generally, broadly speaking, from a therapeutic approach, we can say that there's a broad complex, there's narrow complex. Broad complex comes from the ventricle, narrow complex comes from above the ventricle, supraventricular. This is an example of SVT, supraventricular tachycardia. The paroxysmal, it doesn't really have anything to do with the ECG. It has to do with the presentation. So generally, this tachycardia, it comes in sudden runs of tachycardia. Patient may be fine one moment, the next moment you can have a short run of palpitations. So it's paroxysmal, sudden. So it suddenly comes, happens for a couple of minutes and goes away. It's called paroxysmal. So paroxysmal SVT, PSVT. So this is a little blurry, I know, but I'll still try to zoom it a bit. So yeah, so you look at the rhythm rate, you think it's SVT, supraventricular tachycardia. You go ahead, take the blood pressure. Is it stable? Is the blood pressure, is the SBP more than 90? Yes or no? Let's say it's no. Don't think of anything else. Go ahead and go for DC cardioversion. Anytime, any arrhythmia, if it is unstable, the only answer is DC cardioversion. Let's suppose he's stable. So we'll try some vagal maneuvers. Vagal maneuvers is generally we give a vagal massage. It's over the carotid sinus. We generally press it with our thumb quite deeply. There are some other vagal maneuvers too. So we try that as the first line. If the vagal maneuvers fail to restore the SVT to a sinus rhythm, then we go for therapeutics. The first thing we use is an IV adenosine. IV adenosine, it comes in 6 milligram vials. So whatever, when you draw up the 6 milligram and you give it step. Once your vagal maneuver is filled, you give IV adenosine 6 milligrams. So let's say your IV adenosine works and sinus rhythm is restored. That's fine. You have terminated the SVT. But let's suppose it has not terminated. So you can go ahead and load 12 milligrams next time. So you've already given 6, now you give 12. Total is 18. You can even give one more round. If still after 6 plus 12, 18 mg, there is no response, you can give him 12 more, so up to total of 30. So yeah, 6, 12, 12. Most SVTs will settle by then. If it doesn't settle, then you can use a different class of drugs. You can use either CCBs, which are calcium channel blockers, or beta blockers. And both of these things, they have a negative effect on the heart rate. In CCBs, it generally blocks the AV node, and thus it reduces the heart rate. Beta blockers, it both blocks the AV node as well as the sinoatrial node and reduces the heart rate. You can use either a CCB or a beta blocker. So preferably use IV verapamil for a CCB, and you use IV metoprolol for a beta blocker. If it's unsuccessful, if you have done everything, adenosine 6, 12, 12, you have used verapamil, you have used metoprolol, nothing works, go for synchronized DC cardioversion. Now, in this little red box here is quite important. Before you push your adenosine, ask the patient or his family members if he has asthma. Ask them if he uses any form of inhalers, because adenosine can precipitate asthma. So you can't use adenosine if the patient has asthma. Same for beta blockers. You generally shouldn't use beta blockers for a patient who has asthma, but generally you might use a cardioselective beta blocker like metoprolol. And then calcium channel blockers, where it emerges as the safest option when we're looking at a patient with asthma. Other points are not so important. Just remember the asthma point. Yeah, so I've already answered. This is AFib. Little different from the previous one. You see the baseline is not straight. It is tachycardic, of course. The baseline is not straight. It's a little fibrillatory. It's uneven. And then if you see the distance between the RR intervals, this is short. This is quite long. This is even longer. This is short again. Short, long. The RR intervals keep varying. So it's an irregular rhythm. It's an irregular tachycardia. It's an irregular tachycardia with no P waves. No P waves. It's an irregular tachycardia with no P waves, the fibrillatory baseline. So it's a case of AFib, atrial fibrillation, very, very common. You should know it. Once you have identified AFib, there are 3-4 things you need to know. For an AFib, there are two types of therapy that you can give. One is called the rhythm control, and one is called the rate control. Rate control generally will reduce the heart rate. Instead of maybe the patient is running 160, that will reduce it to 90. That's called rate control. There's one more approach where you change the rhythm to a normal sinus rhythm. This rhythm here is abnormal, right? It's not sinus rhythm. So you use certain medicines which will revert this abnormal rhythm into a sinus rhythm. That's called rhythm control. Just know that much. Generally, we use rate control in most cases. We'll use a beta blocker like metoprolol, and that will reduce the heart rate. We can also use rhythm control, this rhythm control here, and drugs like amiodarone. If the patient is not responding to rate control, we can go for rhythm control. Just know it superficially. And as I told you, any arrhythmia unstable, go for DC cardioversion. Similarly, if the patient has hypotension, pulmonary edema, mitral ischemia, which are all signs of hemodynamic instability, go for DC cardioversion. 200 joule is your first setting, means increase by 100 each subsequent time. There's one more thing that I need to add. This is just the dose. You don't need to remember, just for your reference. Metoprolol. We generally use metoprolol for this. And yeah, digoxin is another drug. The digoxin is used for atrial fibrillation only when it's associated with a heart failure. So if AFib plus heart failure, digoxin becomes a good choice. Other than that, use a metoprolol. Yeah, this is a score. You don't need to memorize this. You can go to any website. You can go to the internet. There's a website called mdcar.com. It has a lot of useful calculators like Curve65 and even this score. It's called the Shad-Vask score. You don't need to remember it. Just remember that it predicts a stroke risk in a patient of atrial fibrillation. And once you enter these values, it will give you a sum total. And on the basis of the sum total, it will give you a recommendation whether this patient needs anticoagulation or not. Just good to know. You don't need to know it, but just remember that there's a score which you can easily calculate. Yeah, what is this? Everyone should get this correct.
Again, people in the chat, what is this? We had discussed this in the last session. VFib. Kavya said VFib.
It's a little bit regular. VFib is generally much more chaotic, much more irregular.
Any other guesses? Prashant said ventricular tachycardia.
Yeah, he's correct. He's absolutely correct. It is a case of VT. And more specifically, it's called a monomorphic VT. Why so? Because each and every complex, if you see, it looks the same. Monomorphic, one form, monomorphous. There's one more type called polymorphic VT. I'm just telling you. I don't have an ECG here. It's generally, it will show a pattern. See, if I draw a baseline, it's straight. Now in polymorphic VT, the baseline will show a pattern like this, undulating pattern. It will go up, come down. That's called a polymorphic VT. So it's got a name. It's called torsade de poids. So for that, you use magnesium sulfate. Just remember that much. We'll focus on the monomorphic VT, what we have here. So yeah, this is a good flowchart. So yeah, you have identified a VT, wide QRS complex tachycardia. It's a VT. Is the patient stable? No. I told you, any arrhythmia, unstable patient, give him cardioversion. Immediate cardioversion, start at 100 joules and keep adding 100 joules. Now, if suppose he's stable, are you sure is the rhythm is VT? Yes, you are. So give him amiodarone. Amiodarone is the drug of choice for VT in most cases. So you start, just know the dose because it's a life-saving drug. You start 150 mg IV over 10 minutes. And then you start an infusion. You don't need to remember the infusion, but just know 150 mg IV is a life-saving dose in case of VT. Yeah, this adenosine is, I told you already. So just remember, stable, amiodarone 150 mg IV over 10 minutes, unstable, DC cardioversion. That's all. The next topic, I'm not going into detail, just know that it's something called hypertensive emergency, very high blood pressure. So it can lead to certain damage in the organs. It's called target organ damage, end organ damage. It can cause some brain damage called hypertensive encephalopathy. The patient can become unconscious, comatose, confused. It can cause aortic dissection, which is basically damage to the aorta. And it can cause many other things actually. Just remember the BP is very high, 200 by 120, and there is evidence of end organ damage. It can be kidney damage, there can be pulmonary edema, there can be myocardial infarction, there can be hypertensive encephalopathy, high blood pressure with some form of organ damage. How will you control this? That is quite important. You have two options. You can give him some oral drugs, IV drugs, or you can give oral drugs. So in IV drugs, generally, I think in most emergency rooms, we see labetalol quite commonly. So just know the dose, 20 to 80 milligrams over 10 minutes, every 10 minutes. Just no labetalol. The other things are just for your reference. No labetalol, it's very commonly used. Right. And in oral, a commonly used drug is nifedipine. Nifedipine is also quite commonly used in most emergency rooms. The dose is 10 to 20 milligrams over 8 hours. You repeat it every 8 hours. Now, nifedipine, 10 to 20 mg, 8 hourly. That's the oral drug of choice, you can say. And for the IV drug of choice, labetalol is very common. All of them can be used, but just remember labetalol and nifedipine. That's all.
Sayan, there is a question. Prashant has asked, sir, there is hypertensive emergency and urgency, both of which is differentiated based on presence of end organ damage. Sir, how can we assess quickly the end organ damage?
Assess quickly, yeah. So you can go organ wise. Suppose the patient has hypertensive encephalopathy. So you check the GCS. The GCS would be low. The patient would be confused. There can be signs of raised ICP. The patient may be vomiting. Then you can go for acute pulmonary edema, very common in hypertensive emergencies. Auscultate his lungs, check his lung base, look for bibasal crackles, and then monitor his urine output. Maybe he has renal failure due to his hypertensive emergency. To check the renal output. So go system wise. Then acute aortic dissection is very classical. Check his right hand blood pressure and left hand blood pressure. If you see a significant discordance, then suspect acute aortic dissection. If the patient has acute coronary syndrome, chest pain, substernal chest pain, typical syndrome, just go system wise. Just go system wise. Generally, I would say check his GCS for hypertensive encephalopathy and listen to his lung base for pulmonary edema and check his urine output. These three things you can check very quickly. I hope that answers your question.
Also, I would like to add, for hypertensive patients, when we start orally, if we start with the amlodipine, and then we move on to say Nicardia in oral drugs, and for IV drugs, we give labetalol, but by that time, you would have probably called the medicine resident. So in an emergency setting, you would most likely say if the patient is conscious and oriented, तो oral drugs से start कर सकते हो. Because these patients would, suppose a patient with 200 BP will come with something like a headache. कि बहुत टाइम से सर दर्द हो रहा है, डाइक्लो लिया, पैन भी लिया, पैरासिटामोल भी लिया, but कमी नहीं हो रहा है. So that time you can start with the oral amlodipine, you can start with the nifedipine, and then eventually, now if the patient has come unconscious, then you would move on to IV drugs, or if the BP is very, very high. Okay, that's just something I wanted to add. Shan, you can continue.
Yeah. The next point is seizures. Generally, seizures, the therapeutic side is very important, but also what is important is protecting his airway. That is a very vital thing that must be done. So generally, a patient with seizure, they're unconscious and the tongue can fall back and block their airway. So you need to position them correctly. So this is a good example of how he's positioned. So he's lying on his back and then his tongue is elevated so that it doesn't fall back. And then you can use an airway adjunct. So as you can see here, this is an oropharyngeal airway. It's also called a Goodell's airway. So yeah, so generally you use it to bypass the tongue and create a airway through the mouth. So it prevents the tongue here from falling back and closing this area, which is the windpipe, which is the trachea. So yeah, you have to protect the airway, which is very important. Apart from that, give oxygen and look for reversible causes. Look for any precipitating cause, because not all seizures are epilepsy. In fact, most of them are not. Most of them are due to some form of electrolyte imbalance or some alcohol withdrawal or hypoglycemia. So as I told you in hypoglycemia section, thiamine and dextrose for hypoglycemia. Also, even in hyponatremia, you can see seizures. And in that case, you shouldn't start the correction yourself. You should call someone senior, because the correction of sodium requires a very precise titration, because if you correct it too fast, it can lead to certain damage in the medulla. It's called osmotic demyelination syndrome. I just mentioned that. So just look for any causes like alcohol withdrawal and hypoglycemia, and secure the airway, which is very important. And this is especially if the seizure takes place outside the hospital. Once the seizure stops, do something called the recovery position. I'll show you in the next slide. This is the recovery position. Patient is lying down. You hold this arm first. You turn it here. This arm you straighten out. This arm you turn it on this side, right? And then you turn the patient over towards you. You turn the patient towards you. And then finally turn the legs. This position, it's a very typical position. It's called recovery position. And this prevents this protects the airway in a manner like sometimes after the seizure, the patient can vomit. And if the airway is unprotected, he can aspirate because he's unconscious. So in this position, the vomit, if he does vomit, it will flow outside. It won't enter his trachea. So that's why you have supported his neck. You have positioned him in such a manner that his airway is protected. Just go online. There are lots of videos how to put a patient in recovery position. It's good to know, especially when the patient is outside a hospital setting where you can't put an airway adjunct device to protect his airway. And this is a very superficial approach to the drugs that you should use. So whatever it is, the first step you must know, it has to be a benzodiazepine. Lorazepam is commonly used. It is given 4 milligrams IM, and it can be repeated also once. So once you have a seizure, just give lorazepam IM. Most patients will recover by then. If not, then you can move ahead. There are many options. You can use fosphenytoin, you can use valproic acid, and you can also use levetiracetam. And if nothing works, then IV anesthetics are used like midazolam and pentobarbital. Not required for you to know. Just know this: how to protect the airway, what is the recovery position, and what is the first drug you should give: lorazepam or diazepam. Use a benzodiazepine. That's all you need to know here. Yeah. Rupali, any questions from anyone?
No questions. You can go ahead.
No questions. Okay. So next is a very, very vital topic: anaphylaxis. Before I start the theoretical part, you have to know the visual things. This typical rash is called hives, also called acute urticaria. Very typical. These are fleeting rash. So if you will see a rash here, elevated wheel you will see in this part. This is slightly red, and then it will recover and it will start here, and it will gradually spread all over the body. It's called anaphylaxis hives, or not anaphylaxis, allergic hives or urticaria. And next thing is this lip swelling, very classical of anaphylaxis. Lip and tongue. The tongue is visible. It's not visible in the first photo. The lip and tongue swelling, very, very important to recognize in anaphylaxis because it can obstruct your airway. A good a sign that you can observe is stridor. If the lips, tongue, and the upper airway have swollen a lot, the patient will exhibit a high-pitched sound while breathing. That is called stridor. So yeah, just remember this skin rash called hives or urticaria, lip swelling, tongue swelling, stridor. These are signs of anaphylaxis, and these are quite worrying signs. If there's just a rash, if there's no breathing problem, no no lip swelling, no other problem, then you can manage it with just anti-allergic agents. But if you see these signs together, lip swelling, you must give adrenaline. This is a very good algorithm. So of course, ABCDEs are must. You first do that. Check the airway. Check whether there is any stridor in his breathing. Check whether his airway is patent or not. Circulation. These patients can have anaphylactic shock and reduced blood pressure. Check for decreased BP, and then disability and exposure. Just look for life-threatening airway and breathing changes, just as I told you. Life-threatening airway changes is stridor, and breathing is stridor. Airway changes is basically swelling in the airway, and skin changes are hives. Raise the patient's legs. This is just because it brings the blood back from the lower limbs. It acts as a fluid bolus, basically, as I told you, passive leg raising in the first slide. Then adrenaline. This number one is adrenaline, oxygen, IV fluids, chlorpheniramine, maleate, hydrocort. Just remember adrenaline, hydrocortisone, chlorpheniramine, and fluids. And of course, oxygen, 5 things. So when I say adrenaline, you must know how to give it. Just knowing adrenaline is not enough. You have to know how to give it. And this is an uh, age-based table. So generally, we must remember the adult dose at least. Adult needs 500 micrograms IM. It's not IV, it's IM, and that's 0.5. So generally, when you open a vial of adrenaline, you'll see that it's written it's 1:1000. 1:1000. That solution, if you take 1 ml of that, that corresponds to 1 milligram. So for you to use 500 micrograms, you need to take half of 1 milligram. So you take half a ml of this solution, 1:1000. This is a solution that you will come across most frequently. There are other concentrations like 1:10,000, but you won't find it commonly. That's using cardiac arrest. This 1:1000, use 0.5 ml of that, give it IM. This is an absolute must for everyone to know. And you should also know the other doses, especially a child less than 6 years. Generally, a pediatric resident will handle this, but it's 0.15 ml. 6 to 12, it's 0.3. Just remember, less than 12, 0.3, more than 12, 0.5 ml. And if it's less than 6 years, a child, 0.15. Just remember this. And then the other two drugs, hydrocort and chlorpheniramine maleate, 10 mg in adults and 200 mg in adults. Just know at least what's in adults. The pediatric part will be covered again, I believe, in our pediatric module. Just remember the dose of in adults. 0.5 ml of adrenaline, 1:1000. Chlorpheniramine maleate, 10 milligrams. Hydrocort, 200 milligrams. Just know this much. Now, of course, you will use fluid. Use IV crystalloids, 500 to 1000 ml. So yeah, adrenaline, chlorpheniramine maleate, hydrocort, and fluids, oxygen. That's all. Yeah, should I move on to stroke?
Yeah, you can move on.
Okay. This is a good mnemonic. It's called fast, fast face, arm, speech time. You can teach this to non-medical people also, so that they can recognize a stroke very fast and can bring patients to the hospital. So yeah, it's very self-explanatory. If their face is drooping on one side, can they lift their arms and legs also? Can they lift their arms? Can they move their legs? S, speech. Are they having difficulties in speech? And time. Time means you have to take him to a emergency department very soon. In India, this number is 108, so you can call an ambulance and take him as soon as possible. So just good to know it's fast. But this is something we use outside the hospital. Inside the hospital, to confirm stroke, we use this proforma. It's called Rosier. It's not used everywhere, but it's good to know. It just has some symptoms of stroke: asymmetric facial weakness, arm weakness, leg weakness, speech disturbance. Basically the same thing. So you can give points to each of it. If they have a seizure, you take away a point. If there's a loss of consciousness, you take away a point. And if the score is more than 1, more than 0 actually, if it's 1 and above, then stroke is a likely diagnosis. I'll come back to the other diagram a little later. So yeah, so you have done fast, you've done Rosier, and you've done ABCDE. The next thing you should do is get an NCCT brain. This is a very important test to do. It differentiates ischemic and hemorrhagic infarcts. The hemorrhagic infarct will show up as a white patch on the CT scan, which is hyperdense and surrounded by a hypodense area, which is an edema basically. This is a big bleed in the area of the internal capsule, and it's got a lot of edema surrounding it. The classical sign of hemorrhagic infarct. This generally goes to the neurosurgeons. This is not an ischemic infarct. It's better to refer to them because they have increased ICT. They can need decompression. They can need craniotomy. But if it's an ischemic infarct, if the NCCT brain shows you nothing out of the ordinary, it just looks normal, then it's an ischemic infarct. So give him an aspirin. Just give him an aspirin and stop every other anticoagulants. And then check what time has elapsed since these symptoms have started. If it's less than 4.5, we generally give alteplase. Alteplase is a thrombolytic agent. It can remove the blood clot that's in his brain. It's generally done by neurologists, and we'll refer this patient mostly to a neurologist for this. But if this time period less than 4.5 is important, alter place is given. But if this time period has passed, there's another intervention called mechanical thrombectomy that can be done. Can be done by intervention radiologists also. Just know that can be done up to 24 hours. And oxygen should be given if the SpO2 is less than 95. So from the point of view of a junior doctor, you won't do much. You just have to document that it's a stroke. You have to document that it's not a hemorrhagic stroke. You have to give aspirin, and you have to quickly check the time that has elapsed and send him for a thrombolysis. That's what our responsibility is. And of course, the other things like if the patient has a very high blood pressure, you have to control that. These are certain guidelines. It just says that if the blood pressure is between 150 to 200, 220, then reduce it to 140, but don't make it drop by more than 16 1 hour. You can just go through it, not very important. And again, the blood glucose, just maintain it at physiological levels and give nutrition, give hydration, basic thing, the supportive management. This page is the supportive management, and this page is the interventions that you need to do to relieve the obstruction. And yeah, and this is the hemorrhagic stroke I already showed you. And I just included this last one slide about poisoning. It's not possible to cover every poison, but you should go through it. Some common ones. I'll tell you, paracetamol is very important. Paracetamol poisoning, acetylcysteine is very commonly used. And apart from this, just know warfarin, vitamin K, and organophosphates, atropine. Just know this. It's not possible to cover it in detail. Let's go through it later. Yeah, that concludes my slides, I think. I have a few references that people can go through where I got it from. I use NICE guidelines, very good evidence-based guidelines. There's something called BMJ visual summaries. So it gives you these flowcharts for every condition, very useful. And this BNF 83 is a book that helps you with prescribing. It has all the drugs, side effects, and the dosages. So you can use that. And apart from this, this is a great book which you can use for acute medicine, all sorts of medical emergencies. And these are certain professional societies which formed some of the guidelines I use today. That's all. Thank you, Rupali. You can take
Thank
over
you so
now.
much, Shan. Does anyone have any questions about what Shan has covered? Otherwise, we'll quickly move on to the cases and then end the session because I know it's been very long. Shan, can you stop sharing? Then I'll share my screen.
Okay, I'll just do it. Okay, share device, stop share. Yep, that's done.
Yeah. Okay. So Shan covered almost everything that we needed to know. Just one thing that is left out that I will be covering is MI. So MI, again, when Shayan covered stroke, he covered ischemic stroke. So that is a plumbing issue in your brain's vessel. Okay, अंदर कचरा फंस गया है vessel में. Now an MI is a plumbing issue in your heart's vessels. Right, so you understand that an ischemia or an infarction is essentially the same logic, that blood के वो heart के musculature को blood नहीं मिल रहा है, oxygen नहीं मिल रहा है, so it's getting ischemic. So in an MI, the patient will usually come with chest pain. Okay, it can be central or left-sided, which radiates to their arm. Sometimes it also goes to the back. So MI का pain एक logic था हमें जब पढ़ाया था. The one logic was it doesn't go below your umbilicus. So it won't be pain that is going down, itna down that it's going below the umbilicus. There are other symptoms also. They might come with nausea, they might come with sweating, dyspnea, feeling tired, jaw pain, right? And there is a very specific thing. Some of these patients will come with a feeling that they're going to die. And that is a valid symptom. It is called a symptom of impending doom. कि हम मरने वाले, ऐसा लग रहा है. That is why they've come to the hospital. And women might have certain different symptoms where they have shortness of breath, fainting, extreme fatigue, and things like that. So it's very easy to identify chest pain. Itna tumhe aana chahiye that, you know, a chest pain patient is coming with maybe nausea and vomiting. You can suspect a MI. There are other differential diagnoses also. But your first thing for any chest pain patient is rule out an MI. How do you do that? And what are the types? Now, an MI patient, when you do an ECG, you will find either an ST elevation, it's a STEMI, or you will get a non-ST elevation, an N-STEMI, where there is a depression instead of an elevation. because the only thing that's happening is necrosis. मतलब जो उसके cells है, they've started dying, and it isn't complete. It is a severe occlusion, but it isn't transmural. That means the entire thickness of the wall, the heart wall, is not included. It's only some part of it. Whereas in an unstable angina, there is no necrosis. It's a minimal occlusion. So that is what the types are, and that is why it's important. Okay, so now you've got a patient with chest pain and you want to diagnose. So the first thing you'll do is you'll get an ECG done, right? On an ECG, you might either get an elevation. You have a STEMI where you have the ST segment elevation. You might get a T-wave depression. That's an ischemia, right? T-wave inversion or T-wave depression, ischemia, and non-ST elevation, MI. Then you move on to doing a TROP-T. Now, as interns, I am pretty sure at some point you will do a TROP-T. You will figure out, it's essentially the same way you do a pregnancy test. It's that quick. And you will check whether you have a positive or a negative. If it is positive, you have a TROP-T, that is TROP-T positive MI, right? Then other investigations, if you've got, you'll send out a TROP-I, you'll send out a CKMB, you'll send out their electrolytes or routine histo, right? Your CKMB or HS-CKMB, which is high sensitivity CKMB, which is a cardiac biomarker. So now, because your muscles, the heart muscles, have started dying, they will start releasing out certain substances. These are biomarkers that you can check. Troponin I, troponin T, CKMB, myoglobin, all of these are cardiac biomarkers. So MBBS interns, you must have had that table that shows this is the first enzyme that rises. Your myoglobin will rise first. Maybe your TROP-T will rise a little later. What stays the longest? What will show you an old infarction? Things like that. So these biomarkers can be investigated and sent out immediately. Okay. TROP-T kits, again, one practical point I'm going to put out. Be careful with the amount of blood you're putting in. If it's too much blood, the whole thing gets covered. Your screen might only get covered, so you will not be able to see positive hai, negative hai, kya hai. And it comes with a subacute syringe, that special TROP-T syringe. And with that, you can collect the blood, or realistically, you used to take a normal syringe and collect the blood, because anyways, you're going to need the blood collection to send out the other biomarkers, right? Okay. Now, this I covered in the ECG section also. How do you locate where the MI is? So depending on which lead is involved in the ECG, if the 2-3 AVF is involved, those are the inferior leads. That means the right coronary artery is involved, or the left circumflex. If lead 1 and lead AVL are involved, lateral leads, and V5, V6, that means the left circumflex or the diagonal of left anterior descending is involved. V1, V2, V3, V4, anterior MI, that means your left anterior descending is involved. Very quick assessment you can do with an ST elevation MI, and you can immediately figure out which artery is likely to be involved. Now, this is again all at your level. What you do as an junior doctor is this much. Beyond this, you can do a 2D echo, you check the perfusion, you check other parameters, echo karate hain, then the cardiologist move on to that. But at your level, if you can locate it, you can do the primary management, that is good enough. Okay, so we have a patient with ischemic chest pain. We've done an ECG. We got an ST elevation. It's an ST elevation MI. We did not get an ST elevation, so we did a TROP-T, and based on its result, if we got a normal TROP-T, that means negative hai, it is unstable angina. If the TROP-T is positive, that means it's a non-ST elevation MI. Very simple algorithm, very simple flowchart. The more patients you see with practice, it will get easier. And this is essentially what the differences are. In an unstable angina, there is a clot, but it is not completely occluding your vessel. Whereas in an end-STEMI, there is a clot. It is not completely occluding, but it is big enough to cause a myocardial necrosis. That means it's big enough to cause the death of the myocardial cell. In an ST elevation MI, the whole thing is occluded. Your full vessel is gone. Major plumbing problem needs to be cleared out immediately. Right? Your enzymes will be elevated, the symptoms will be more severe, and things like that. Management, very common mnemonic we use. Monac, morphine, oxygen, nitroglycerin, aspirin, clopidogrel. At your level, if you can remember Monac, that is good enough. Morphine usually dete nahi hai India mein. It is not usually given. We generally give nitroglycerin, sorbitrate, sublingual dete hain. And oxygen, if the saturation is dropping, or in general, if you feel the patient has a need, if they're agitated, if they're anxious, you can put them on oxygen. Aspirin, 160 to 325 milligrams of aspirin you give orally. Again, clopidogrel, 300 milligram orally. This is a longer mnemonic, which is Monarch and Basic. For the MBBS interns, I'm sure you had at some point written a MI answer, and this basic mnemonic covers everything. Morphine, oxygen, nitrates, aspirin, reperfusion, which I'll cover in the next slide, thrombolysis or PCI, clopidogrel or prasugrel, heparin, beta blockers, anticoagulants, statin, ACE inhibitors, correction of risk factors. So your beta blockers, anticoagulants, statins are something that continues lifelong. एक बार अगर patient को MI हुआ है, aspirin will continue lifelong for them, because you have to make sure that it doesn't happen again. Aspirin, what category of drug is aspirin? Can anyone tell me in the chat? What is aspirin? What is aspirin? क्या दे रहे हो तुम patient? NSAID, okay. Antiplatelet. So when a clot is being formed, that in your vessels of your heart, it's platelets to clot banate hain. So logically, we give an antiplatelet drug, right? And that same logic, now you've given an antiplatelet drug, you've given the statins and everything. Next thing you do is you have to break the clot. Ab clot ban gaya hai. If the patient has come within 12 hours, right, since the symptoms started, you can do something called a PCI, percutaneous coronary intervention, which is the gold standard treatment. मतलब this is the best possible treatment for the patient. क्या करते हैं हम एक device डालेंगे, ठीक है, percutaneous, very minimally invasive. We'll go to that vessel, which we located using the ECG and obviously using echo and further. But suppose you know it's this here, you've done it, and you go in, you break the clot, right? You see that what they're doing is they're breaking the clot and they're putting a stent. Because तुमने clot तो तोड़ दिया, but it might form again. To prevent forming the clot again, there are certain stents that are put, which release drugs. These are called drug-eluting stents, where these will continuously give out certain drugs that will prevent formation of another clot. Because at any point in your body, if you're putting a foreign body inside, tum stent dal rahe ho, your body will think it's an outside device. I need to get rid of it. I need to fight it. I need to make a clot again. So that is why you put in drug-eluting stents to prevent a formation of a reclot. Now, if the patient has come after 12 hours, which is the more realistic thing that happens in India, ambulance will take another 2 hours, 3 hours to respond. Then to get from, maybe if they're coming from a rural area to the hospital will only take them 7-8 hours. Then getting the doctors and all of that. Mostly they come after 12 hours. Okay. Now, if the patient has come after 12 hours, you can still thrombolyze, but you give a drug. This is called alteplase. As Sayan mentioned, even in stroke patients, the same logic you're doing, you're trying to break the clot. Patients will sometimes tell you, with a chest pain patient, if you're taking a previous history, कि पहले कभी ऐसा हुआ है, they're like, हाँ, this I remember very specifically because there was a patient. पहले हुआ था, उन्होंने एक इंजेक्शन दिया था, 15,000 का था. Again, a very expensive injection costing 15,000 rupees to break the clot. That is alteplase. Right? So once you start working as physicians, you also start realizing the cost of interventions and how it can also be a clue when you're taking a history. So that again a relevant history if the patient has had a previous MI and they're on certain medications and things like that. Okay, now this is your basic management. Overview, monarch, basic, and monarch. This much you know, good enough. Okay, we'll move on to the cases. 35-year-old male brought to the casualty after falling from a bike with a bleeding head wound and multiple fractures. BP systolic is 18, diastolic you're not able to ascertain. Respiratory rate is 22, but the patient is still conscious. What would you like to do? You can put it in the chat or you can unmute. Fluids, good. So as Sayan explained, we will start with fluids. We will rather start with crystalloids, right? So my fluid dena hai. This is an unstable patient. You want to resuscitate, bring them to a normal BP level. BP padhana. Okay, good. Case 2. 75-year-old male brought to the casualty, complaints of left-sided chest pain since morning and difficulty in breathing. Blood pressure is 180 by 110. ECGs show to the following. What is your immediate management? What would you like to do? First of all, what can you see on the ECG? And what would you like to do? Good. Anterior wall MI, right? And I just covered MI, so you know the immediate management is monarch, morphine, oxygen, nitroglycerin, niacin, clopidogrel. Case 3, 55-year-old male came to the casualty with complaints of facial weakness on the left side, weakness of the upper and lower limbs on the right side since the past 2 hours. Patient is a known hypertensive and diabetic on medication. Currently, BP is 200 by 110. HGT, that is the blood sugar, is 250 milligram per deciliter. Now, this again, Sayan covered immediately. He showed you the proforma. So it is asymmetrical weakness. एक side का weakness है, upper and lower limbs, facial weakness. The relatives have brought in and given you a history कि चेहरा एक तरफ से deviate हो रहा था, face was drooping. So again, you will think that it's a stroke, and your investigation, as Sayan mentioned, is a NCCT brain because you have to rule out if it's ischemic or hemorrhagic. Case 4. 17-year-old comes to the casualty with complaints of itching and hives over the body, as you can see in the image. There is no difficulty in breathing. Respiratory rate is 20. How you manage this? What would you like to do? Good. So you would like to give a hydrocort and you would like to give an AVIL, right? Someone has mentioned dexamethasone. Before that, or actually you would give a AVIL and a hydrocortisone before you give a dexamethasone. Also, if she had difficulty in breathing, as Sayan explained, you would give adrenaline. I'll give you an example. Last night around 1:30, around 2 a.m. to 2:30, a 70-year-old auntie was brought in with complaints of same difficulty in breathing and hives. Now she is known allergic to milk products, and at 1:30 she decided to have kheer for celebration. So she came in, she had difficulty breathing. We gave her AVIL hydrocort. Her saturation was 70. And then we immediately put her on NRBM. Saturation recovered to 99. But even so, her saturation would, after we removed her off NRBM, saturation was dropping to 90. So our next step would have been giving adrenaline. But by then the medicine resident came, we found out she was an asthmatic also. So we gave her a neb and all of that. But point being, they might come with difficulty in breathing. So you will have to give AOL hydrocort and adrenaline. Last case, 40-year-old male roadsider brought unconscious to the casualty, chronic alcoholic for 20 years, BP 140/80, blood glucose 35. Apart from dextrose, what would you like to give? Now, this is a very common case scenario. Half of the patients that you get will be alcoholics. झगड़ा करके आए हैं, गिर के आए हैं. Very common. Very good, Ajish. Very good, Terence. CME, as Shayan explained, what the logic behind it is. We want to prevent Wernicke's encephalopathy and Korsakoff psychosis. Right? Okay, guys, that's it. This was a long session, I know, and I'm sure you're tired now, but we'll end it here. Thank you for staying till the end. And if you have any questions, you can ask on the WhatsApp group itself. Shayan is also there. I'm also there. We'll be happy to answer any questions, and I'll send the presentation on that. Thank you for joining. Thank you, Shayan, for taking a wonderful session and for going in so much depth and making sure we know all of the dosages and everything and making us better doctors. Thank you, everyone. You can end now.